All right, so this is the Fetal Monitoring Certification Review course. All right, so to get started, give yourself some credit. Even though you guys are new, there's still a lot that you do know. Make sure you take your time and read the questions. Simple little things like greater than, less than. I'm notorious for that. I'm like, oh, I already know the answer before I even finish reading it, and then I get it wrong because like the word not is in there, or other than, or something like that. So just take your time, read it, practice, practice, practice. You guys got some time, so this is good. You'll get this information ahead of time, and then, you'll kind of know more on what to do. The night before your exam, make sure you get a good night's sleep. Make sure you eat. Have a well-balanced breakfast. Don't be too sugared up. If some of these questions seem easy, that's because you already do know the answer. So even though you guys have just been doing this a short while, I think a lot of this is going to make sense to you too. Quiz yourself. Don't waste time on studying the stuff you already know. So if you guys know something cold, move on to the next thing. In one of the handouts that I'm giving you, the one that says NCC, somewhere in there is a breakdown of the course of what's going to be on the test. Like there's a X amount of percentage is going to be on physiology, and then a lot of it is going to be on strip review. They're not going to try and trip you up. It's not going to be like how we say, oh, we got a variable, you know what I mean? Those don't really, I mean, they do exist, but they don't exist in this world. So they want to know that you know what you're looking at and what the appropriate interventions are. So, like I said, for me, I didn't waste my time reviewing strips or things like that. Where I spent my course of my time was not necessarily a pH value of cord gases, but like the rest of the cord gas values, because I don't know those off the top of my head. pH is yes, the rest no. And baroreceptors, chemoreceptors, parasympathetic, sympathetic nervous system, which one does what. So that's where I had to spend the majority of my time. Also, I'll see if I can make copies of some test questions that I do have a copy of, and I have a lot of them. And so what you can do is just kind of review those, see where you're doing really well, and then see where you're struggling. If you notice that you're making the same mistakes over and over, focus in on that and study that one. All right, so the certification in electronic fetal monitoring is a national exam, and it's provided by the National Certification Corporation. This is a national exam, not regional. So there's going to be lots of discussions on practices that are not seen locally. So that doesn't mean that they're wrong. So for example, amnio infusions. Just because we don't do that does not mean it won't be on the exam. I guarantee you it's going to be on the exam. So those are just, and we're going to go over that too. But that does put us at a slight disadvantage when we don't do the high risk stuff, because there will be high risk stuff, there will be preterm stuff, and which we'll cover that too. So that might be where you actually want to spend some of your time as well. All right, this is the one I was telling you about, so you can even mark this down if you want. I was telling you it's in your paper there. So on slide 4 here in the NCC candidate guide. So there's going to be 125 questions that you have to answer. 100 of those questions are going to be counted. That's what you're going to get graded on. Somewhere in there are going to be 25 embedded test questions that they are just using to determine if they are good test questions or not. So they're using you as a guinea pig. You don't know where they're going to be. So if something to you just really doesn't make sense, like, what the hell are they talking about? I don't understand this. It might just be an embedded question. So try not to stress over it too much. Also, the one good thing about this test is you can skip a question and come back to it. That's a double-edged sword. It's great that you don't have to waste your time on it. I believe you get 2 full hours for this exam. I don't think you're going to need full 2 hours, but take it if you need it. The downside to that is don't miss one. Do you know what I mean? Like, make a mental note. I do believe the one good thing about this test is if you go to submit it and be like, hey, you missed question number 13, you have to go back and answer it. So I don't think it allows you to skip one, but don't take that for granted. All right, each question has a stem and 3 alternative answers. So a lot of times you can just read over your answers, and you can definitely eliminate at least one, and then at least that gives you a 50-50 shot. The answers are alphabetical, and there's no penalty for guessing. So if you really don't know something, take a guess. It tests for basic knowledge and application of knowledge. The EFM tracings are set at 3 centimeters per minute, which is our normal standard tracing that you see on the paper, not necessarily what you see on the screen. I mean, it is, but we all know that the screen is enlarged. And you'll have 2 hours to complete the exam, like I said. All right, the exam content. It applies the knowledge of maternal fetal assessment methods, interprets data from the EFM to differentiate between actual fetal data and equipment failure. And again, we'll go over all this. Apply knowledge of fetal heart rate regulation to the interpretation of EFM data. Identify and interpret the significance of fetal heart rate patterns, and apply knowledge of common pregnancy problems. Know your policies. So I can't stress this enough. All the policies that we have here are all A1 guided. So A1 standards, you have to meet A1 standards. You can go above A1 standards if you like, but you have to, at a bare minimum, have to meet those standards. So if you know the policies, you should be in pretty good shape. These are the ones right off the bat that you absolutely have to know. Your cervical ripening, whether that's mechanical or chemical, and your induction policies, fetal monitoring interpretation and the interventions that go with it, your OB hemorrhage, your your hypertensive crisis, your neonatal resuscitation, all right, and shoulder dystocias, just to name a few. Fundamental principles. So variable, late, and prolonged fetal heart rate decelerations reflect interruption of oxygen transfer from the environment to the fetus at one or more points along the oxygen pathway, and we'll talk about that later too. The fetal heart rate patterns inform us of fetal acid-base status at the time they are observed, and that's probably going to be a test question as well. So everything we do is based on, the fetal acid-base status. And we all know that when we're looking at our monitoring strip, it's at the time that's occurring. So you might have a perfectly well oxygenated, neurologically intact fetus at the time that you're looking at it, and that could change at any point in time. So the fetal status can change rapidly under certain circumstances that will impede circulation, such as an abruption or an eclamptic seizure. There's also a possibility that the fetus can suffer an insult at some point during gestation and resolve the acid-base balance well enough to have a category 1 tracing. So meaning they may have had some sort of little infarct at some point, and now they've compensated. So by the time we get them, they still have a category 1, but then they come out and there's obviously something that had happened, but it necessarily wasn't anything that we did. All right, a finding of a normal umbilical blood gas measurement precludes the absence of acidemia or at or immediately before birth and is more objective measure than the APGAR score. So kind of just what I was saying at the time that you're looking at it there. A fetus exhibiting either moderate variability or accels of fetal heart rate, damaging degrees of hypoxia, induced metabolic acidemia can be reliably excluded. So basically what that just says is that if you're having some accelerations, like I said, you have moderate variability, then you're looking at a neurologically intact, well oxygenated fetus at the time that it's being observed. All right, fetal oxygenation consists of 2 basic parts. The transient transfer of oxygen from the environment to the fetus and the fetus's response to interrupted oxygen transfers. So there's certain fetal heart rate patterns that provide reliable information regarding both of the basic elements of fetal oxygenation. And when we look at the fetal oxygenation, you have to remember one main thing. The fetus is not getting oxygen from the lungs. The fetus is actually getting oxygen from the blood that comes from the placenta. In addition, you can remember a couple of rules. The arteries are going away from the heart and the veins are going towards the heart. So it's a little bit backwards than it is in us. So just remember A, arteries, A, away, okay? And then, veins, that's the one thing that we're looking for, the big umbilical vein when we drop a UV line. So that's the one that you want. So the oxygen and nutrients from the mother's blood are transferred to the fetus through the placenta via the umbilical cord. So the oxygenated blood travels to the baby's heart. It bypasses the lungs. And I believe that might actually be a test question in some way, shape, or form, if I remember, because it will send blood to the lungs to perfuse the tissue, but that's not where the oxygen transfer is happening. That's all happening in the placenta. So yeah, sure.
I think some of these slides were missing. The last one I have that I'm on along with you? Is this one?
Yes, I'm on this one right here. Yeah, okay. So, yeah. So, I'm sorry. So, yeah, let me, I'll tell you what slide I'm on then. For the one that I'm recording, it'll make more sense. But I'm sorry. Yeah, good point. I didn't realize that you don't have notes. Some of them do. Some of them will have like little bullet points on there. And then ones like this, it's just me trying to tell you what's going on. So, yeah, so we're on slide 8 right now. All right. So, and I wish I tried to get a better picture of like I know this is a mannequin, but it's a really great model. And if you could see it a little bit better, you could really see like the insides, and you could see where there's a hole, the foramen ovale, which has a hole that goes directly from the right side to the left side of the atrium. And that's how the blood goes through. So the blood bypasses the lungs. Like I said, it will perfuse the lungs as far as getting blood to the tissue, but it doesn't do the oxygen transfer there. So, like I said, enters the heart directly through a special opening called the foramen ovale and a shunt called the ductus arteriosus. Both of those close after the baby's born. So once that baby takes its first breath, those should shut. All right. Next slide. All right, slide 9. Factors affecting fetal oxygenation. Are your slides numbered?
Yes.
Okay. Okay, so these are some of the factors that affect fetal oxygenation. Extrinsic, meaning the outside, which is the mother. Intrinsic, inside the fetus. So maternal oxygenation, uterine blood flow, placental exchange, umbilical cord flow, and as far as intrinsic, inside the baby, fetal circulation, oxygenation of the tissues, and fetal heart rate regulation. So some of these will go through quicker than others, and then some of them are more detailed later on down the line. All right. This one's actually hard for me to read because it's small, but we'll see what we can do. All right, essential principles. Fetal oxygenation involves the transfer of oxygen from the environment to the fetus along the oxygen pathway. You will need to know the oxygen pathway. So as you can see, it goes from maternal lungs to the heart, to the vasculature, to the uterus, to the placenta, through the umbilical cord and into the baby. And there's things along the way that can happen that can interrupt that flow. You can see in the lungs, there's embolisms, there's asthma as we go down, tachycardia, arrhythmia, diabetes, hypertension, rupture, bicornuate uterus, that's just a uterus bone too. Hypertension, diabetes, implantation, abruption, compression, deformity, and a true knot. So the oxygen is carried from the environment to the fetus by the maternal and fetal blood along the pathway that includes, like I said, the maternal lungs, the heart, the vasculature, the uterus, the placenta, and the umbilical cords. And these samples are included to demonstrate where extrinsic issues may exist. So, and like I said, we'll explore those a little bit later. Much of the intrinsic issues, so within the baby, can exist in acute or chronic state. And it's near impossible to determine from external field monitoring alone. So again, we'll get into those as we get down further. You'll see this a couple times, actually. Maybe not this exact looking slide, but you'll see it. So the oxygen depletion cascade. As this happens, the baby is deprived of oxygen. It triggers a cascade that ultimately leads to metabolic acidosis. When a fetus experiences lack of oxygen or hypoxia, the cells resort to anaerobic metabolism to produce energy. So it starts out in aerobic and then goes to anaerobic. This generates lactic acid as a byproduct, which increases the acidity, which that's where you get your low pH from of the fetal blood. So when you do your cord pHs and you get that low pH, that's what that's coming from. All right, and that results in metabolic acidosis. So the buildup of lactic acid can also deplete buffering systems in the blood, which further contributes to the severity of the acidosis. So here's a little bit more of a detailed breakdown. The baby's going through the normal blowing off of their CO2. The fetal metabolism is in aerobic metabolism. So we're starting from the beginning. Everything's fine. This is working well for them. They can exchange all the CO2 and they keep their blood at a normal pH. But as hypoxia happens, and this can arise from various causes like placental insufficiency or maternal anemia or hypertension or even interpartum events like umbilical cord compression or an abruption. This low oxygen level in the blood will result in tissue hypoxemia. And when the oxygen is insufficient, the cells can't get enough and can't efficiently generate energy through aerobic respiration. So they switch to anaerobic metabolism, which produces less energy but it generates lactic acid as a byproduct. So the lactic acid builds up. It leads to an increase in hydrogen ions, which are responsible for the acidity. And this increases your hydrogen ions, which reduces the pH. Again, that's where you get your low pH. And this results in metabolic acidosis. So this means the blood becomes abnormally acidic. And the fetal acidosis can lead to a range of fetal distress symptoms, including low pH, fetal distress, and poor APGAR scores. And that might be where you get your HIE kids that you have to cool, because you see them come in with their pHs in the toilet. All right, maternal oxygenation. These are your extrinsic factors. Adequate pulmonary function. Sorry, we're on slide 12. Adequate pulmonary function in the obstetric population. You can have respiratory depression due to medications, seizures. Again, if mom is seizing, she's not breathing. So there's your respiratory depression right there. Central nervous system depression, pulmonary embolism, amniotic fluid embolisms, pulmonary edema, pulmonary pneumonia and adult respiratory distress syndrome, and asthma and atelectasis. So consider the available oxygen in the maternal system related to ventilation perfusion mix match, the diffusion defects, or obstruction. So some of the examples, like I said, would be asthma. You get your smokers, also smoke inhalation, meaning like from a fire, carbon monoxide exposure, pulmonary embolisms, or pneumonia. Cool. Consider the possibility of respiratory suppression, such as when administering narcotics or mag sulfate, or in the presence of seizure activity. All right, slide 13. Maternal oxygenation, the extrinsic factors continued. More than 98% of oxygen diffused from the pulmonary alveoli combines with the hemoglobin in the maternal red blood cells. The other 1 to 2% remain dissolved in the blood, and it's measured by the partial pressure of dissolved oxygen. That's your PaO2. That's inside the red blood cells. A normal adult PaO2 value of 95 to 100 results in a hemoglobin saturation of approximately 95 to 98%. And that's indicating that the hemoglobin is carrying 95 to 98% of the total amount of oxygen that it's capable of carrying outside of the RBCs. So normal PaO2 value of 95 to 100, like I said, results in the hemoglobin saturation, and that's where your kids get their oxygen carrying capability. Slide 14. So continuing on, from the lungs, the pulmonary veins carry the oxygenated blood to the heart. And again, this is mom. So mom is getting her oxygenated blood from the lungs. The babies do not. All right, and then the blood enters the left atrium with a PaO2 of approximately 95 to 100%. The oxygenated blood passes from the left atrium through the mitral valve, through the left ventricle, and out the aorta for distribution throughout the body. So while not the primary focus, the maternal physiology is a key element in the understanding of fetal heart rate patterns and interpreting the EFM tracings. So the exam will test knowledge of how maternal physiology affects fetal oxygenation and how to recognize and address potential complications. It covers areas like the impact of maternal conditions on fetal health and the effects of maternal interventions on fetal heart rate. Slide 15. Interruption at the level of the maternal heart can include altered heart rate, so an arrhythmia, reduced preload due to hypovolemia or compression of the inferior vena cava. That's why we like to get them on their left sides a lot. Impaired contractility, so they have ischemic heart disease or cardiomyopathy. Again, we don't usually see these people, knock on wood, although you never know what's going to walk through that door. But things that you're going to have to know anyway. Increased afterload due to hypertension, that we do see a lot of. Structural abnormalities, so will they have valvular stenosis or insufficiency, pulmonary hypertension, or coarsitation of the aorta. So in a healthy obstetric patient, the most common cause of reduced cardiac output is reduced preload, such as with hypovolemia or compression of the inferior vena cava. The coarsitation of the aorta is just a narrowing of the large blood vessel of the aorta that leads from the heart. All right, slide 16. The maternal vasculature. So oxygenated blood leaves the heart, travels to the uterus via the systemic vasculature. So the aorta goes down the iliac vessels and enter the uterine arteries. From the uterine arteries, the oxygenated blood travels through the arcuate arteries to the radial arteries, and finally the spiral electrodes. Sorry, I got FSC in my brain. The spiral arteries before exiting the maternal vasculature and entering into the intervillous space of the placenta. Slide 17. All right. The interruption of oxygen transfer at the level of the maternal vasculature can be related to, like we said, hypotension due to regional anesthesia. So a lot of times when our girls get epidurals, you'll see they'll have a quick drop in blood pressure. And I always say if you can fix the mom's blood pressure, usually you can fix the baby, because you'll see if they get hypotensive, you're going to see a drop in your heart rate. Hypovolemia due to dehydration or hemorrhage, again, you're going to have your fluid boluses. Impaired venous return, impaired cardiac output, certain medications, and vasoconstriction of the distal arterioles in response to the endogenous vasoconstrictors and medication. So this narrowing reduces the blood flow to these areas, which can have both normal physiological functions and potential problematic consequences. The potential problems in pregnancy can include preeclampsia, which we do see a lot of, intrauterine growth restriction, and pregnancy-induced hypertension. And that's why we tend to get those kids delivered sooner rather than later. Those aren't the ones you're going to want to sit on until 40, 41 weeks. I don't know how well you guys can see this slide. We're on slide 18 now. It's a little bit small for me. Hopefully it's not too small for you. But maternal hypotension, so you have the decrease in maternal blood flow, which leads to an acute impairment of the uteroplacental exchange, which leads to decreased PO2. And then the reflex of the peripheral vasoconstriction in the fetus, which creates a rise in blood pressure. And then the fetal heart rate decels from the autonomic response to the rise in blood pressure. And oftentimes that can result in profound bradycardia, like you see on the strip there. Slide 19. Excuse me. Maternal supine hypotension. And this is just a good picture, I think, of why we like to get moms on their side and why we don't like to keep them on their back very, very often. So you can see there on the picture on the left where the mom is supine. So that red square and that blue square are your superior vena cava and your inferior vena cava, or your aorta and your inferior vena cava. So those are your greater vessels. And as the baby's lying on there, he's putting pressure on those. So if you roll them to their side, and it doesn't matter left or right, they tend to get off those vessels. So the compression of the inferior vena cava interrupts the blood return from the lower extremities. Supine positioning results in a decreased stroke volume secondary to decreased blood return to the heart, as you can see, because it's getting squished. Compression of the inferior vena cava in pregnant women after 20 weeks can produce up to a 30% reduction in cardiac output. So supine hypotensive syndrome is characterized by supine hypotension in late pregnancy, whose clinical presentation ranges from minimal cardiovascular alterations to severe shock resulting from inferior vena cava compression by the gravid uterus. And that comes straight from the Journal of Forensic Science. So that's in there because that will probably be a test question in some way, shape, or form. Slide 20, uterus. So the interruption of normal oxygen transfer at the level of the uterus commonly results from uterine contractions that compress intramural blood vessels and impede the flow of oxygenated maternal blood into and out of the intervillous space. And remember, that's where the oxygenation takes place in the placenta. The less common causes include uterine rupture or trauma. And that would be an abrupt thing that you would see. Slide 21, tachysystole. And this is a good picture of it. So greater than 5 contractions in 10 minutes averaged over a 30-minute time period. So you need to really look at your 30 minutes in order to determine if you have tachysystole. And as a side note, using the Obix, you have those the tools, the e-tools in there. Those are great for things like this because you can but you have to put your cursor at the beginning of your 30-minute window and put it at the end of your 30-minute window. And that is how it's going to average it out for you. And then you hit the button and it will tell you if you are 15 plus, that means you're in tachysystole. So a lot of times I like to use that because some providers really like to push PIT, and you may argue, no, I'm in tachysystole, I can't. And they may argue, no, you're not. And then that is one way you can use your tool. And then you can pop it up there and it says 16 and you can be like, I'm in tachysystole. Legally, I cannot up your PIT. And so that's a good way for you to kind of protect yourself because sometimes you know, they can kind of press you a little bit. And if you're not used to standing up to them, you might cave. So you got to protect yourself. All right, so this is further qualified by the presence or absence of fetal heart rate decelerations, meaning if the decelerations are present, it suggests fetal distress and necessitates immediate interventions. If the decels are absent, the situation may still be concerning and further monitoring or intervention may be needed. The presence of decelerations alongside tachysystole is a serious concern as it strongly suggests fetal distress due to inadequate placental blood flow and or oxygenation. This requires immediate interventions such as discontinuing Pitocin, repositioning the mother, administering oxygen, and potentially using tocolytics. You guys know what tocolytics are? Okay, it's like your tubuline. Okay. And this applies to spontaneous labor as well as stimulated labors. So again, if you look at that picture, this kid is not getting a break. There's no resting tone there. I mean, you're not even getting 60 seconds worth of oxygen into your kid. So that's really important. All right, the placenta is the maternal-fetal interface that facilitates the exchange of gas, nutrients, waste, and other molecules, for example, antibodies or hormones and medications, between the maternal blood in the intervillous space of the placenta and the fetal blood in the villus capillaries. So, the most common cause of acute interruption of oxygen transfer at the level of placenta is the separation of the placenta from the uterine wall. So, abruption, bleeding, placenta previa. Fetal maternal hemorrhage and vasoprevia should be considered in the appropriate clinical setting. So, and we're going to get into this in a little bit further down, but just to let you know, so vasoprevia is a rare serious pregnancy complication that occurs when fetal blood vessels grow abnormally and it runs across or near the cervix and it's blocking the birth canal. If left untreated, the vessels can tear during labor or when the water breaks, causing severe blood loss in the fetus and the mother. And the signs include painless vaginal bleeding, fetal bradycardia, and ruptured membranes. So when you break a woman's bag of waters and you see all sorts of blood coming out, you're probably going to see a drop in the heart rate. There's a chance that she could have a vasoprevia. And there's going to be a picture later on down the road here where you can see it later on. All right, slide 23, the uteroplacental blood flow. So the uterine blood flow increases from approximately 50 milliliters per minute to 700 milliliters per minute during pregnancy, so quite the jump. It accounts for 10 to 15% of maternal cardiac output. 70 to 90% passes through the intervillous space, and the intervillous space perfusion depends on the adequate uterine blood flow. So oxygen is diffused from the intervillous space across the blood-to-blood barrier and into the fetal blood. The PaO2, the partial pressure of oxygen in the umbilical vein returning to the fetus, is in the range of 35 millimeters of mercury, and the fetal hemoglobin saturation is between 50 to 70%. Interruptions in the maternal circulation have detrimental effects on perfusion of the intervillous space. 24, factors that may decrease uteroplacental blood flow. So extrinsic, remember that's mom. We got tachysystole, hypertonus, and abruption. Maternal hypertension, so again, that supine position, any kind of analgesias or anesthesia. So your Nubanes, your Stadol, not that we really use Stadol anymore, or anesthesia can also do it. Maternal hypertension, placental changes that include decreased surface area, edema, degenerative calcifications, infarcts, and infections. So maybe the kid had a stroke in utero, calcifications. You'll see a calcified placenta when they're old, or you may see it from a smoker. Vasoconstriction, so your exogenous, that's your symptomatics, and except for ephedrine. So the placental changes may occur in the presence of diabetes, chronic smoking, and then a hypertension for some examples. Sympathomimetics are stimulant compounds which mimic the effect of the endogenous, which is your internal cause, agonist of the sympathetic nervous system. Side effects may include hypertension, reflex bradycardia due to the hypertension, or tachycardia, dizziness, nausea, vomiting. All right, slide 25. Crossing the placenta. So we have simple diffusion, the O2, the CO2, narcotics, facilitated diffusion, so glucose, active transport, your amino acids, your calcium, your potassium, your phosphorus, your iron, pinocytosis, your IgG, your phospholipids, bulk flow, so that's your H2O, your electrolytes, capillary breaks or leaks, intact blood cells, independent movement, your tryptonium pallidum, infections such as toxoplasmosis. So the simple diffusion moves from the area of higher concentration to lower concentration along a concentration gradient that's passive, and it does not require energy. So that's your passive diffusion. Your facilitated diffusion moves along a concentration gradient with the assistance of a carrier. So active transport moves against a concentration gradient with the assistance of a carrier molecule and requires energy. So the proteins will act like tunnels or carriers along the molecules to move down the concentration gradient from an area of higher concentration to lower concentration. So your pinocytosis, transfer of minute engulfed particles across a cell membrane. So the ingestion of liquid into a cell by the budding of small vesicles from the cell membrane. The IgG are just the antibodies that play a crucial role in the immune system. And the phospholipids are the major components of the cell membrane. And like I said, the Toxoplasma gondii, that's the parasites that cause toxoplasmosis. 26. So chronic vascular issues like those created by chronic smoking, diabetes, allow for poor nutrition and delivery to the tissue, creating poor growth. So you can see that ugly looking placenta right there. All right, 27, umbilical cord. After oxygen combines with fetal hemoglobin in the villus capillaries, oxygenated blood returns to the fetus by way of a single umbilical vein within the umbilical cord. So the interruption of the normal transfer of oxygen to the fetus at the level of the umbilical cord most often results from mechanical cord compression. Uncommon causes can include vasospasms, thrombus, atherosclerosis, hypertrophy, hemorrhage, inflammation, or a true knot. So poor qualities of the Wharton's jelly, true knots, entanglements, fetal position, oligohydramnios, and a prolapsed cord can all attribute to compression, contributing to poor umbilical flow to the fetus. The umbilical vein is red. It carries oxygenated blood from the placenta to the fetus, and the arteries are the blue, and they carry deoxygenated away from the fetus and back to the placenta. All right, moving on. So this is just the oxygen pathway and some of the causes for the interruption in oxygen transfer, and they're located at each level, along the oxygen pathway: your lungs, your heart, your vasculature, uterus, placenta, umbilical cord. And you can see them all there. Respiratory depression due to narcotics or MAG. Apnea and seizures due to eclampsia. Like I said, if you're having a seizure, you're not breathing. So pulmonary embolism or pulmonary edema, pneumonia, adult respiratory distress syndrome, asthma, atelectasis, those are your collapsed lungs. Reduced cardiac output, hypovolemia, compression of the inferior vena cava, regional anesthetics, cardiac arrhythmias. In the vasculature, you got hypotension, hypovolemia, compression of the inferior vena cava, regional anesthetics again, medications such as hydralazine, labetalol, nifedipine. The uterus, excessive uterine activity. Again, it's not getting that break. Uterine stimulants such as prostaglandin or oxytocin. So you would want to stop those. And uterine rupture. Placenta, you have the placental separation. Rarely vasoprevia, but it can happen. Rarely fetal maternal hemorrhage. And placenta infarcts, infections, usually confirmed retrospectively, but umbilical cord compression, and a cord prolapse, which is a true knot, and a true knot. All right, 29, velamentous cord insertion versus the vasoprevia. So I told you I was going to give you a picture. I apologize if they're really small for you. I don't know if you have a way to blow them up, but they're actually pretty good pictures if you can actually see them. So the velamentous cord insertion, the cord inserts into the membranes surrounding the placenta, and the vasoprevia, the fetal blood vessels run through or near or over the cervix. So I want to talk about the velamentous cord versus the previa. So the velamentous insertion of the umbilical cord. This is a condition where the umbilical cord inserts into the membranes surrounding the placenta rather than directly into the placenta itself. Vasoprevia, on the other hand, is a condition where the fetal blood vessels run, like I said, through the membranes, over or near the cervix. The velamentous cord insertion is a significant risk factor for vasoprevia, as the unprotected blood vessels run through the membranes in a velamentous cord insertion and can be vulnerable to rupture. So when the membranes rupture during vaginal delivery. So a velamentous cord insertion is where the cord attaches to the amniotic or chorionic membrane instead of the placenta. In the velamentous insertion, the umbilical cord vessels branch out and they travel through the membranes before reaching the placenta, leaving them exposed and unprotected by the Wharton's jelly. So it's common in monochorionic twins where the twins share one single placenta, and it's less common in single twin pregnancies. The risk with that is that it can lead to vasoprevia, fetal hemorrhage, fetal distress, and potentially stillbirth. It's often diagnosed on ultrasound during the second trimester. With the vasoprevia, they're unprotected blood vessels from the umbilical cord or the placenta, and they're located in the amniotic membranes and across the cervix. The unprotected vessels are vulnerable to rupture during labor or when the membranes rupture. They're less common than the velamentous cord insertion, but they're more dangerous if not diagnosed early. There's a risk of fetal hemorrhage, fetal death, and potential maternal complications if not managed properly. So it's often diagnosed during ultrasound, like I said, particularly in cases where the velamentous cord is suspected. So the velamentous cord insertion is a significant risk factor for previa, like I said, vasoprevia. Early detection of both conditions is crucial for proper management and to minimize the risk to the fetus. The vasoprevia occurs in about 1 out of 2 to 3,000 births, and the risk for fetal exsanguination and death with the ruptured membranes is really, really high. So initially you get some fetal tachycardia, the baby tries to compensate, and then bradycardia with the sinusoidal pattern. And oftentimes you'll have fetal mortality with a 60% mortality rate, which is very high. Even if you quickly rush back for C-section, sometimes you can end up with an unsuccessful outcome. And if you looked at that picture, you could see why. All right, slide 30. Review question. So if you see review questions, that's because there's been questions like that on your tests. So oxygen is transferred from the mother to the fetus via the placenta through, which one do you think? And I kind of got the answer right there. So simple passive diffusion, hydrostatic pressure, or active transport. So simple diffusion. It moves from an area of high concentration, which is the maternal blood, to an area of low concentration, which is the fetal blood. And this movement is driven by the oxygen partial pressure gradient between the mother and the fetus's blood. Another review question. Perfusion of the intervillous space is dependent upon what? Maternal oxygenation, number of fetal villi, adequate uterine blood flow. Adequate uterine blood flow. And I can tell you that is one of the most important questions you're going to get, and you might get it in a couple of different ways. So that's really, that's almost really like EFM in a nutshell, adequate uterine blood flow. That's what it's all about. All right, one more review question. The maternal fetal exchange is best supported by which maternal position? Right, left, or either right or left? And honestly, the answer, I know we put everybody on their left side a lot, but it's really either one. You just want to get them off those greater vessels. So either one is correct. All right. Do we need to take a little break? Are we in good spot? Should I keep going? You guys good? You want to keep plowing through? All right. If you need a break, let me know. All right, moving on to slide 34 in fetal circulation. This is super hard to see, at least it is for me. But again, this is one of these ones, if you can find a way to blow this picture up, it really gives a good indication of your fetal circulation. So like I said before, and I said it before, I'm just going to reiterate it again pretty quick. Blood does not enter the fetal lungs for oxygenation. This occurs in the placenta. So the fetal circulation from the placenta to the fetus involves the umbilical vein, which carries the oxygenated blood. So remember, it's reversed in babies. It carries the oxygen, nutrient-rich blood from the placenta to the fetus. The blood then flows through the ductus venosus, which is a shunt that bypasses the liver. So we're going from the placenta and working our way up the picture here. Okay, it allows the blood to enter the inferior vena cava into the right atrium of the heart. The right atrium receives the oxygenated blood, which is shunted through the opening called the foramen ovale. If you remember, I told you that is the hole that goes from the right atrium to the left atrium. and that closes over once you take your first breath. So, like I said, literally just a hole that goes from the right side of the atrium to the left side of the atrium. As we're born, we take that first breath, the hole closes. And so then as adults, you and I both have the little calcification in our heart where that hole used to be. So the blood then passes to the left ventricle and it's pumped via the aorta, which is the body's largest artery, and it goes out to the systemic circulation. The aorta carries the oxygenated blood to the rest of the fetal body, including the brain and the heart, and the deoxygenated blood, which carries waste products back from fetal circulation, are returned to the placenta via the umbilical arteries, which also carries blood back to the placenta. So, again, fetal oxygenation is opposite of ours. The arteries are carrying the deoxygenated blood away from the fetus. Remember I said arteries away? So remember, the arteries away, veins carry oxygenated-rich blood to the fetus. That's why we have one big umbilical vein, and that's why we use the umbilical vein to drop the umbilical catheter for our very sick kids. So when we talk about the UV lines, that's what we're talking about. That's why I always say if you have a kid that's not doing so well, leave a long leash, because we can always cut it back a little bit. All right, the shunt. Several anatomic shunts, so the foramen ovale that I just mentioned, the ductus arteriosus, they allow for the presence of oxygenated blood in both atria, because remember that's that hole and the blood just goes back and forth. The ductus venosus allows for relatively well oxygenated blood to enter the heart directly, bypassing the liver. And the shunts normally close rapidly with the expansion of the neonate's lungs at birth. All right, this is just a little glossary of words here for you. So affinity is how readily the hemoglobin acquires and releases oxygen molecules into the fluid that it surrounds. The hemoglobin is the protein contained in the red blood cells that's responsible for delivery of oxygen to the tissues, and the hematocrit measures the volume of red blood cells compared to the total blood volume in the red blood cells of the plasma. Moving on to 37, acidemia. So, metabolic acidemia versus respiratory acidemia. So, metabolic acidemia is caused by an accumulation of lactic acid in the setting of anaerobic metabolism. Respiratory acidemia is caused by an accumulation of CO2, a byproduct of aerobic metabolism that can increase when the blood when the placenta gas exchange is suboptimal. So in contrast to metabolic acidemia, isolated respiratory acidemia has no known association with adverse outcomes. So remember your oxygen pathway or the oxygen depletion cascade on slide 11, because like I said, that's going to be on your test, and I can almost guarantee you there's also going to be a test. So write this one down too, number 37, between metabolic acidemia and respiratory acidemia. 38. And as you can see, I got quite a few slides in here on fetal oxygenation because it's really important, and they're going to ask you many questions and many different ways about it. So, how does a fetus survive in an environment with a PO2 value equal to that of an adult venous blood? So, when compared to the adult, the fetus has a high hemoglobin concentration, high O2 affinity, and high cardiac output and heart rate. So the higher the concentration of the hemoglobin allows for an increased oxygen carrying capacity. The average, and I put these in here because they may test you on this too. The average hematocrit in a term fetus is 51 to 56%. The affinity, or as I like to call it, the grip or the stickiness of the fetal hemoglobin is higher. So in translation, the fetal hemoglobin is able to grab onto the oxygen molecules and hold on to them and release them better than adult hemoglobin. So remember, cardiac output is heart rate times your stroke volume. Babies cannot control their cardiac output or their stroke volume. They can only control their heart rate. So the functionality of the fetal heart allows for higher cardiac output and faster heart rate than that of the adults. So now you have the fetus that can grab and hold on to more oxygen, has a higher carrying capacity, and then circulates through the fetal system more efficiently than that of the adult cardiovascular system. But I do believe, if I remember correctly, that there was a question about cardiac output, stroke volume, and again, the answer is the babies can only control their heart rate. They can't control the stroke volume or the cardiac output to a certain degree. All right, definition check again. I apologize if these are a little hard to read. I'm looking at it now and I'm realizing that red is a little bit harder on the screen, so I apologize. Hypoxemia, that's your decreased oxygen content in the blood. Hypoxia is reduced tissue oxygen content. Acidemia is increased hydrogen ion in the blood, so that's where you get your decreased pH. And acidosis is an increased hydrogen ions in the tissues. 40. Fetal compensatory responses. So you have the redistribution of fetal blood flow favoring vital organs. So blood flow to the heart, the brain, the adrenal glands is increased 2 to 3-fold, while blood to the gut, spleen, kidneys, and limbs are decreased because they're going to shunt. So decrease in O2 consumption. As the fetal heart rate slows in response to the hypoxia, the myocardium consumes less oxygen. With moderate hypoxia, the fetal oxygen consumption drops to 50% below the normal level. So 41. So your fetal oxygenation. So true IUGR versus SGA. Which one is it? So feti may be well oxygenated, healthy, and basically just small. A fetus with true IUGR is already compromised by an interruption in the oxygen pathway and is redistributing the available oxygen. That's why we got to get these kids. You'll see us induce someone at 37, 38 weeks for IUGR because they're already compromised. So you let them go too long and you may not have a viable baby. So SGA, these fetuses are typically well oxygenated and can and will tolerate the stress of labor with minimal to no signs of distress. IUGR, therefore, will be less tolerant of the process of labor before showing signs of stress, such as late or prolonged decelerations and or minimal variability. And anytime you see a quote in here, it's because there's usually a question of some sort. So when the placental transfer capacity is near 100%, the fetus is provided with approximately twice the resources it needs to grow and will be well oxygenated. So this is also known as the fetal reserve. However, at less than approximately 75% of maximal transfer capacity, fetal nutrition is limited and intrauterine growth restriction may evolve. If placental function is reduced beyond 50% of maximal exchange, oxygen and carbon dioxide transfer decrease and fetal compromise can result. 42, and I apologize, I used the same slide twice, the same picture. I didn't mean to, but it happened. All right, in the presence of severe acidemia, you have a decreased cardiac output, decreased blood pressure, and decreased blood flow to the brain and heart, and that results in tissue damage or even fetal death. So, neonatal signs consistent with acute peripartum event, intrapartum event. The pH and the acid-base excess or the base deficit are useful values in assessing the fetal condition at the time of the collection when establishing whether an acute interpartum event is sufficient to cause cerebral palsy. Blood pH values below 7 have been associated with adverse neonatal outcomes and more clearly represent a threshold for significant fetal acidemia. So really you don't want to see one. 7.2 is normal. So you don't really want to see one definitely below 7. So you'll see if we get the cord pHs and they come back 6.9 or something, we're like, eek. So that kid's probably going to have to be cooled. All right, moving on. And once again, I think this is like my third slide in some way, shape, or form, just a different way of talking about the oxygen depletion cascade and the oxygen pathway because it's that important. So if you know nothing else, just the best you can, commit it to memory at least till you take your test. Because you know it when you see it, you just don't, on the monitor, you just don't know that perhaps exactly what you're looking at. But so the oxygen depletion cascade, as this happens and the baby is deprived of oxygen, it triggers a cascade that ultimately leads to metabolic acidosis. And metabolic acidosis will be on your test, which is why we're kind of hitting it a few times. When a fetus experiences a lack of oxygen, so hypoxia, like I said, the cells resort to anaerobic metabolism to produce energy. This generates lactic acid as a byproduct, which increases the acidity, which is where you get your low pH of fetal blood, resulting in metabolic acidosis. You get the buildup of lactic acid, which can also deplete your buffering systems in the blood, further contributing to the severity of acidosis. So a more detailed breakdown is the baby is doing the normal blowing off of the CO2, like we mentioned. The fetal metabolism is in aerobic metabolism. So you're starting off okay, it works well. They exchange all the CO2. They're keeping their blood at a normal pH, but then you have a hypoxic event, and it can arise from various causes, like I said, like placental insufficiency, maternal anemia or hypertension, or even interpartum events like an umbilical cord compression or an abruption. This low oxygen level in the blood will result in tissue hypoxemia. When the oxygen is insufficient, the cells can't efficiently generate energy through the aerobic respiration anymore, so they switch to anaerobic metabolism. That produces less energy, but that's where you start getting your lactic acid buildup. And as it builds up, it increases your hydrogen ions, and that's responsible for the acidity. So the increase in the hydrogen ions and the acidity reduces the pH and the fetal blood, and that results in the metabolic acidosis. So that means the blood becomes abnormally acidic, and that's why you get those low pHs. So fetal acidosis can lead to a range of fetal distress syndrome symptoms, including a low pH, fetal distress, and poor APGAR scores. All right, fetal cardiac output, slide 44. Compared to that of an adult, fetal stroke volume does not fluctuate significantly. So the fetal heart rate is what drives your cardiac output in the fetus. So remember I told you they don't control the output or the stroke volume, just your heart rate. So baseline variations have little effect until you start getting a kid that's tachycardic, and tachycardia like greater than 240, bradycardia less than 60. So the stroke volume, and I know that's not the definition of tachycardia, but in this instance, for the affecting the fetal cardiac output, it would be over 240. So the stroke volume in the fetus does not fluctuate significantly, thereby making fetal cardiac output primarily rate dependent. So your normal baseline variations will have little effect on cardiac output until you get extreme rates of 240 beats or bradycardia at 60 beats are reached, and at which time fetal cardiac output can be significantly decreased. Next slide. So the cardiorespiratory center is in your medulla oblongata. It determines your fetal heart rate baseline, your variability, and your pattern. Coordinates input from the intrinsic influences, so your autonomic nervous system, your parasympathetic nervous system, your sympathetic nervous system, your baroreceptors, which are located in your aortic arch and your carotid, your chemoreceptors, which are in your central and peripheral, your endocrine system, your sleep-wake cycles, breathing, sound, and temperature. So the sympathetic nervous system and the parasympathetic system play distinct roles in regulating body functions. So with the sympathetic system maturing earlier than the sympathetic prepares the body for your fight or your flight response. The parasympathetic promotes rest and digest, or feed and breathe, if you will, activities. The sympathetic activation increases your heart rate, your blood pressure, and it prepares the fetus for potential stressors of labor. The parasympathetic activity is more prominent during rest and digestion, potentially influencing the variability during labor. And I can guarantee you're going to see a question on your test about the parasympathetic and the sympathetic. So just know that the sympathetic speeds up. That's how I remember it. And the parasympathetic is, slows down. Another one, your baroreceptors, your chemoreceptors play a crucial role in regulating fetal heart rate and blood pressure. So the baroreceptors respond to changes in pressure within the blood vessels, while chemoreceptors respond to changes in the chemical composition of the blood, such as oxygen and carbon dioxide. So I just remember that baroreceptors, blood pressure, and chemoreceptors, chemical. It's baroreceptors. I spelled that wrong. Sorry. The baroreceptors' primary function is to detect changes in arterial blood pressure. They're located in the aortic arch and the carotid sinuses. And the stimulation of the baroreceptors is increased pressure leads to a decrease in the heart rate via the parasympathetic vagus nerve. So that's where your kid bagels itself. And conversely, the decreased pressure stimulates the sympathetic nervous system, increasing your heart rate. So remember I said sympathetic speeds up. So this is also a good picture depicting that. It's a little small, but at least I can read it, so hopefully you can read it. And it's just there for you to get like a visual. All right, slide 47, parasympathetic. So the vagus nerve originates in the cardioregulatory center and innervates the SA node and the AV nodes. That's your acetylcholine mediated. Your inhibitory influence slows your heart rate, which determines your baseline fetal heart rate. The vagal influence can rapidly decrease fetal heart rate. So that's responsible for your variables. So what does that all mean? The stimulation of the vagus nerve comes from your medulla oblongata. Remember we said, and it goes to your SA node. That's down your right vagus. And the AV node, which is your left vagus. And it triggers the release of acetylcholine from the nerve endings, causing a decrease in the firing of the SA node, which that's going to slow your rate of transmission to the ventricles, thereby slowing down your heart rate. Okay. Preterm versus term. So your average baseline fetal heart rates at 20 weeks is about 155, 30 weeks 144, and at term before labor is 140. And we all know these can fluctuate. Resting baseline decreases with advancing gestational age only by about 10 beats per minute, so not a lot. So, but you know, comparing your 28-weeker to 30-weeker, you can see it's not much. Any preterm fetus with a baseline fetal heart rate greater than 160 should be evaluated further to rule out fetal compromise rather than just assuming tachycardia is secondary to prematurity. Your sympathetic nerve fibers throughout the myocardium and the vasculature. So you got your catecholamine, epinephrine, norepinephrine, your mediated stimulatory response, your sympathetic nerve terminals, the adrenal medulla. Increased heart rate contractility produces fetal accelerations in response to stimulation and fetal tachycardia. Vasoconstriction, hypertension, preserves central brain perfusion in times of stress. So the fibers in the heart are stimulated, they trigger the release of epinephrine, norepinephrine, and in turn produce an increase in the fetal heart rate. Your baroreceptors. So pressure detecting sensory nerve fibers, they're stretch receptors. They're located, like I said, in your aortic arch, in your carotid bifurcation. The stimulation leads to increased vagal outflow, which lowers your heart rate and reduces your cardiac output. It's key role in variable decelerations from cord compression and decelerations, which leads to bradycardia in response to fetal hypertension. So, found in the carotid sinus wall and the aortic arch, the baroreceptors are responsible for the regulation of blood pressure. So I said that before, that will be a question in there. An abrupt increase in blood pressure, such as that created by cord compression, will in turn cause a sudden decrease in fetal heart rate as the fetus attempts to compensate and maintain oxygen. So a cord occlusion leads to decreased fetal blood pressure, stimulated by the baroreceptors, leading to a variable decel. So that's a good little way to remember that, because there will be a question about your cord occlusion and is it baroreceptor, is it chemoreceptor, what's going on. So you're going to want to remember that one. All right, chemoreceptors. Chemosensitive cells, they detect the decreased PaO2, increase your hydrogen ions, increase your PaCO2 in your central medulla oblongata. The stimulation leads to an increased sympathetic outflow, which leads to tachycardia and hypertension. Your peripheral, located in your aortic arch and your carotid bodies, increases your parasympathetic outflow. The hypoxemia is related to D cells, so your lates and your variables, and it's associated with hypoxia. So you get your prolonged decelerations and your bradycardia. So the functionality of the chemoreceptors are better understood in the adult than in the fetus, but in the fetus, the chemoreceptor stimulation has been described in the mechanism of both a late and a variable decel, resulting from umbilical arterial occlusion coupled with hypoxemia. So in both these cases, the blood flow falls below the threshold for a normal respiratory gas exchange. You get your increased PCO2, It stimulates the chemoreceptors and results in the activation of the cardioregulatory center, and it slows the fetal heart rate. Okay, hormonal. The adrenomedulla. Stress-induced catecholamine response, so your epinephrine, your norepinephrine, your sympathetic nervous system responses, you get your increased heart rate, your vasoconstriction, your cardiac contractility, and your tachycardia. So your central shunting to the brain, the heart, the adrenals for self-preservation. So the fetus responds to stress by releasing hormones that affect fetal circulatory regulation, allowing maximal perfusion to vital organs. And that primarily the fetal brain, the heart, and the adrenal glands is where all the blood shunts to. The key hormones in this regulation are epinephrine and norepinephrine, arginine, vasopressin, and the hormones in the renin, angiotensin, aldosterone system. Sleep-wake cycles. And this is for a near term. So the sleep-wake cycles emerging during the third trimester also influence the fetal heart rate. Your state 1F is similar to a quiet sleep, while state 2F is similar to active sleep. So your active sleep, meaning there's more active stage where the fetus might be experiencing rapid eye movements, breathing irregularities, and other physical activity. And you can see the associations there with the state 2 and the active REM. You get your moderate variability, your ACT cells, and your fetal movement, and a reactive NST. You get frequent body movements, whereas state 1, infrequent body movements, it's your quiet sleep. You get minimal variability or non-reactive NST. So again, we might have a kid on the monitor. You'll see great category 1 strip. You have ACT cells, and then all of a sudden it gets kind of flat. And if you're around me long enough, you'll always hear me say babies are allowed to sleep, and this is exactly what I'm talking about. So they might just be in that quiet sleep stage. Having said that, if it's more than 20 minutes, then you want to start trying some maneuvers, fluid bolus, etc. You can also do, if you're worried about it, you can do like a scalp stim. If you guys know what a scalp stim is, yes, no? Yeah, so you go in, you do a vag exam, and you'll just take your finger and you just kind of tickle the top of the baby's head, and that theoretically that should elicit a response for the baby to increase its heart rate, and you'll get an ACT cell. You can also do a vibroacoustic stimulation. So if you don't want to put your hand in there for whatever reason, you could take like the buzzer that we use to the razor that we use to shave people. If you turn that on without the blade, it makes this buzzing noise. Please. You just put it right over the top of the baby, and that vibroacoustic should elicit a response as well. Side note, you never ever want to do a scalp stim on a baby when they're in the middle of a decel, which we used to do all the time when I was a new baby nurse, because that can bagel your kid. So you don't want to do that. So never in the presence of a decel. But if they're sleeping and you're worried about it, try it. All right, homeostatic interactions. Maintenance of acid-base status determined by placental blood flow supply and oxygen delivery. The placental is the fetal organ for respiration. It provides oxygen and removes CO2. Bicarbonate buffering system maintains your normal pH, and it's important for cellular and organ function. So fetal monitoring is an ongoing indirect assessment of physiological factors, both extrinsic and intrinsic, so remember mother and baby, to the fetus that affect the fetal oxygenation. The fetus depends on uterine blood flow and placental exchange, umbilical flow, oxygen transport to the tissues, and innate compensatory factors that control the fetal heart rate when challenged by labor and other stressors. So a couple more review questions. Late decelerations are mainly initiated by vagal response, chemoreceptors, or baroreceptors. And that is baroreceptors. So baroreceptors, you get the reduced delivery of the oxygenated blood to the intervillous space. Remember, that's in the placenta. And that can reduce the diffusion of oxygen into the fetal capillary blood in the chorionic villi, leading to a decline in fetal PO2. And that's below the normal range of approximately 15 to 25 millimeters of mercury. If the fetal PO2 falls below critical threshold, the chemoreceptors detect the change and signal the medullary vasomotor centers to initiate a protective reflex response. So your sympathetic outflow causes peripheral vasoconstriction and centralization of the blood volume, and that results increased in peripheral resistance, causing a rise in the mean arterial pressure and a subsequent baroreceptor-mediated reflex, which slows the heart rate to reduce the cardiac output, and then it returns the blood pressure to normal. Number 2, you get your parasympathetic branch of the autonomic nervous system, which stimulates the reaction from what fetal heart rate, and that's your decrease rate. Remember I said parasympathetic slows down. So, and you can also think of, if you can't think of para slows, you can think of para, which is pokey, and if you're pokey, then you're slow. All right. Sorry about that. I had a rogue computer for a minute. Okay, so fetal response to interruption. So, like I said, depending on the frequency and duration, the interruption of the oxygen transfer at any point along the oxygen pathway may result in progressive deterioration of fetal oxygenation. The cascade begins with the hypoxemia, which is decreased oxygen content in the blood. In that term, the hypoxemia is characterized by an umbilical artery, PaO2, below the normal range of 15 to 25. And again, like I said, we've seen this a few times now. All right, the fetal response to the interruption. So you have normal homeostasis, which requires an adequate supply of oxygen and fuel in order to generate the energy required by basic cellular activities. Recurrent or sustained hypoxemia can lead to decreased delivery of the oxygen to the tissues and reduced tissue oxygen content, which is hypoxia. And if you remember way back in the beginning, we had that triangle. Actually, it's been in there a couple of slides, actually. You had that triangle for your, where it goes through your cascade system. So, fetal response to interrupted oxygen transfer continued. When the oxygen is readily available, the aerobic metabolism generates energy efficiently in the form of ATP. Byproducts of aerobic metabolism include carbon dioxide and water. When the oxygen is in short supply, the tissues may be forced to convert from aerobic to anaerobic metabolism. So that's a big one, remember I said on your test. And it's generating energy less efficiently and resulting in the production of lactic acid. The accumulation of lactic acid in the tissues results in metabolic acidosis. The lactic acid accumulation can lead to utilization of the protective buffer phases, primarily bicarb, to help stabilize the tissue pH. If the buffering capacity is exceeded, the blood pH may begin to fall, leading to metabolic acidemia. And it's critical to distinguish between metabolic acidemia and respiratory acidemia. So remember I showed you that slide a few slides back. I told you you're going to want to memorize that. There will be another slide coming up too, where we're going to hit on that a little bit too. So the respiratory acidosis is primarily due to a lack of oxygen and accumulation of carbon dioxide, while the metabolic acidosis is caused by a buildup of lactic acid due to the body's switch to anaerobic metabolism when oxygen is insufficient. Fetal acidosis is often respiratory, but if oxygenation doesn't improve it, it can quickly progress to metabolic acidosis. And that, in a nutshell, is pretty much what you're going to want to remember. So that's a pretty good description of it, I think. Metabolic acidemia is caused by an accumulation of lactic acid in the setting of anaerobic metabolism. Are you sick of hearing that yet? If I'm saying it more than once, then there's a reason for it. Respiratory acidemia is caused by the accumulation of CO2, a byproduct of aerobic metabolism, and then the increase in the blood when the placental gas exchange is suboptimal. And in contrast to metabolic acidemia, it's isolated. Respiratory acidemia has no known association with an adverse outcome. And this is a good way, they may or may not have questions on your test, how you're going to figure out if they're in respiratory or metabolic alkalosis versus acidosis. So as you can just see, increase in pH and a decrease in PaCO2, you're going to have your respiratory alkalosis. If you have a decrease in pH and an increase in PaCO2, you're going to have respiratory acidosis. And just the opposite with your metabolic, a decreased pH and a decrease in bicarb, you're going to have your metabolic acidosis. With an increased pH and an increase in bicarb, you're going to have metabolic alkalosis. So if you can kind of remember that little picture right here somehow, some way, then, and it's really, I don't think it's that bad to memorize it, but if you can memorize that, that'll really help you out a lot on your test. All right, moving on. Umbilical cord gases analysis. So the growing fetus depends on maternal blood supply for oxygen and nutrients. The fetal and maternal circulation is proximate at the placenta, where the gas and nutrients exchange take place between the maternal and fetal circulation. The oxygen and nutrients diffuse across the placental membrane from the maternal arterial blood, and it's transported to the fetus via a single large umbilical vein. So following the extraction of oxygen and nutrients, the fetal blood returns to the placenta via two small umbilical arteries. This deoxygenated blood contains the waste products of fetal metabolism, including PCO2, and it's then eliminated from the maternal circulation via the lungs and the kidneys. So she breathes it out and she pees it out. So slide 64. The large umbilical vein carries oxygenated blood to the fetus. Remember what I said before? The arteries are away, the vein is too. So the two smaller arteries carry deoxygenated blood and waste from the fetus. Therefore, the venous blood sampling reflects the combined effect of maternal acid-base status and the placental function, while the arterial blood sampling reflects the neonatal acid-base status. That's why it's important when we get our cord pHs that we label them, because they do make a difference. If you get them mixed up, sometimes you can even tell that they're mixed up when you look at them, but not necessarily. After separation from maternal circulation and throughout life, oxygenated blood is carried in the arteries from the lungs to the tissue, and deoxygenated blood is carried from the tissues back to the lungs in the veins. So asphyxia, slide 65. Asphyxia is reduced tissue oxygen, so hypoxia, of sufficient severity and duration enough to cause metabolic acidosis. All right, when the cells are severely depleted of oxygen, you get your metabolic acidosis that develops, which leads to anaerobic metabolism, which leads to lactic acid that gets released into the bloodstream. So for as many times as I said that about the lactic acid buildup and everything, that's kind of it in a nutshell. So you can kind of refer back to slide 65 for a down and dirty, quick little way to remember it. All right, and this is, I know we've seen 15 different slides on oxygen pathways because it bears repeating. This is just another different visual way for you to try to remember it. I'm a very visual person, so and the oxygen transfer can be disrupted at any one of these points, and it can manifest as a fetal heart rate decel, so your variables, your late, your prolonged. And the degree of oxygenation disruption is the important factor. It doesn't matter so much as to where it happened. It's, the degree to which it happens. But just know that it can happen on any single one of those. 67. Pardon me. Cord blood metabolic acidosis is characterized by low pH and high base excess. So your cord blood respiratory acidosis is characterized by reduced pH with a normal base excess, and your respiratory acidosis at birth indicates impaired gas exchange and reduced oxygen delivery to the fetus. So you're going to want to remember this slide too. So 67, put that on your window review before you walk in for your test. And then here are your normal cord blood values. Your artery, your pH 7.2 to 7.3, PCO2 45 to 55, PO2 15 to 25, acid-base deficit less than 12. Your venous, pH 7.3 to 7.4, PCO2 35 to 45, PO2 25 to 35, and your base deficit of less than 12. And so you can see they vary a little bit there. PO2 above 55, there's something going on. If you have an O2 below 15, there's something going on. And a base deficit greater than 12, something's definitely going on somewhere. Side note, I believe this was a test question on this, and I said this before, but it bears repeating. I kind of touched upon this, but not exactly. So if you do a scalp stim, and remember, like I said, we don't do them during decels, but if you do a scalp stim and you elicit an ACT cell, then you can be pretty rest assured that you have a pH of at least 7.19. And remember, 7.2 is normal, but at least 7.19. And that will be on your, at least it was on my test, 7.19. So again, and these are at the time that we're looking at it, but scalp stim, you get an ACT cell, you got a pH of at least 7.19. So again, that means you're looking at a well oxygenated, neurologically intact fetus at the point that you are looking at it. All right, 69. Only 100 more to go, children. Try to get the other ones will go by a little quicker when we start getting into better things like the strips, but I know this is kind of it. All right, so regardless of the specific cause of the interruption in fetal oxygenation, recurrent or sustained tissue hypoxia and acidosis can lead to a loss of peripheral vascular smooth muscle contraction, reduced peripheral vascular resistance, and hypotension. 70. If interrupted oxygen transfer progresses to the stage of metabolic acidemia and hypotension, multiple organs and systems, including the brain and heart, can suffer hypoperfusion, reduced oxygen, and lowered pH and reduced delivery of fuel for metabolism. So the interruption of the normal cellular metabolism can lead to cellular dysfunction, tissue dysfunction, and even death. Injury threshold. We reviewed a few or more than a few fetal oxygenation in detail, including each step of the oxygen transfer from the environment to the fetus and each stage of the fetal physiological response to interrupted oxygenation. We reviewed the mechanism of injury and the setting of recurrent or sustained interruption of oxygenation and the precise relationship between interrupted fetal oxygenation and the neurologic injury, which is complex and incompletely understood. The electronic fetal heart rate monitoring was introduced with the expectation that it would significantly reduce the incidence of neurologic injury. So specifically, they thought it was going to help prevent cerebral palsy caused by an interpartum interruption of fetal oxygenation. In recent years, it's become apparent that most of the cases of cerebral palsy are unrelated to interpartum events and therefore cannot be prevented by interpartum fetal heart rate events. So maybe they had like a stroke in utero or something. Nevertheless, a significant minority of such cases may be related to interpartum events and it might be preventable. So that's why we do what we do. Okay, markers for hypoxic ischemic encephalopathy. So these are your HIE kids. Neonatal signs consistent with acute peripartum or interpartum events. So your APGAR scores of less than 5 at 5 and 10 minutes. Fetal umbilical artery acidemia, so your umbilical artery pH of less than 7 or a base deficit less than 12 or both. So it's important to note that fetal injury is uncommon even when metabolic acidemia is present. So it's important to understand that respiratory acidemia is not a recognized risk factor for fetal injury. The second criterion highlights an equally important point, and that's intrapartum interruption of fetal oxygenation does not result in cerebral palsy without first causing moderate severe neonatal encephalopathy. All right, 74. Neonatal signs consistent with acute peripartum or interpartum event. So your presence of multisystem organ failure consistent with hypoxic ischemic encephalopathy. That can include renal injuries, hepatic injuries, hepatologic abnormalities, cardiac dysfunction, metabolic derangements, and gastrointestinal injuries, or a combination of any of these. A sentinel hypoxic event immediately before or during labor, a sudden and sustained fetal bradycardia, or the absence of fetal heart rate variability and the presence of persistent lates or variable decels, usually after a hypoxic sentinel event when the pattern was previously normal. APGAR scores of 0 to 3 beyond 5 minutes. And remember, if you're under 7, you're going to keep going every 5 minutes until you either get above 7 or, baby's pronounced dead. I think I missed one there, sorry. The physiology of fetal oxygenation involves this sequential transfer of oxygen from the environment to the fetus and the subsequent fetal response if the oxygen transfer is interrupted. Interruption of the normal oxygen transfer can occur at any point along the oxygen pathway. Recurrent or sustained interruption of normal oxygen transfer can lead to progressive deterioration of fetal oxygenation and potential fetal injury. However, significant metabolic acidemia, so you have an umbilical artery pH of less than 7 and an acid-base deficit of greater than 12, has been identified as an essential precondition to interpartum hypoxic injury. So less than 7, greater than 12 acid base. Those are your base excess rather. Those are the two that you really want to look at. With respect to the relationship between the fetal oxygenation and potential injury, there's a consensus in the literature that interrupted oxygenation does not result in fetal injury unless it's progressed to at least the stage of significant metabolic acidemia. So in summary, the physiologic basics of fetal heart rate monitoring can be summarized in a few key concepts. The objective of interpartum fetal heart rate monitoring is to assess fetal oxygenation during labor. Fetal oxygenation involves the transfer of oxygen from the environment to the fetus, and the subsequent fetal response of oxygen transfer is interrupted. And once again, we got that oxygen summary here. The oxygen is transferred from the environment to the fetus by maternal and fetal blood along the pathway. That includes the maternal lungs, the heart, the vasculature, the uterus, the placental, and the umbilical cord. The fetal response to interrupted oxygen transfer involves a sequential physiological response. So you get hypoxemia, which leads to hypoxia, which leads to metabolic acidosis, which leads to metabolic acidemia. So everything that we've been talking about in a nutshell is right there in red. And you will have to know that. Fetal injury due to interrupted oxygenation does not occur unless this process has progressed at least to the stage of significant metabolic acidemia. So an umbilical artery pH of less than 7 and a base deficit of greater than 12. Insult to injury. In the presence of initially normal fetal heart rate tracing that develops an abnormal pattern in the absence of a catastrophic event, the progression to significant acidemia can happen in 60 to 90 minutes. So your whole tracing. The components of fetal heart rate tracings do not occur in isolation. Therefore, evaluation of fetal heart rate patterns should take into account all components of fetal heart rate patterns, including your baseline rate, your variability, and the presence of accels or decels. Your EFM tracing should be assessed over time to identify changes or trends. A complete description of the EFM tracing includes uterine contractions, baseline fetal heart rate, baseline variability, presence of accels, periodic associated with the contractions, or episodic not associated with the contractions. They just happen, periodically. Decelerations or changes of trends with the fetal heart rate pattern over time. So the focus is not to be applied to any one part of the tracing being reviewed. Recurrent decels, although in need of observation, are not indicative of a need for immediate delivery, depending on the other factors that need to be considered. So examples may include a multip versus a primate, 2 centimeters versus 9 centimeters, and the presence or absence of moderate variability in acceleration. So you want to take into consideration all those things first. So, operational principles continued. There's no differentiation between short-term and long-term variability. They're usually visually determined as a unit. The fetal heart rate patterns are dependent on gestational age and an essential factor in the interpretation. Prior fetal assessments, the use of medications, and maternal status also need to be considered because they can change. Okay, so EFM tracing. So we're going to be looking at uterine contractions, your baseline rate, your baseline variability, the presence of accels, the periodic or episodic decelerations, and changes or trends over time. So accelerations during the interpartum period are not required, although they should be included in the documentation when present. A key principle in understanding the fetal oxygenation in the antepartum and the interpartum period is that moderate variability with or without accels reliably predicts the absence of fetal metabolic acidemia at the time that the tracing is being reviewed. The opposite's not always true. So the absence of accels or moderate variability does not reliably predict metabolic acidemia. So you can have a reactive strip without accels, and you can still have a category 1 strip. So for your baseline fetal heart rate, approximate mean of the fetal heart rate rounded to increments of 5 beats per minute. So it's read over at least 10 minutes. You only need a 2-minute minimum. So we all know we've all had those strips where, you know, some of it might be missing, or she's sitting up, you're not tracing mom, whatever the case may be. Over the 10 minutes, you need, or sometimes it can be, you know, all over the place. But over those 2 minutes, you need to be able to piece two minutes, and it doesn't have to be continuous. So, pardon me. So, you know, if you can pick a minute over here and a minute over there, and you can put them together, then that's good enough, as long as it's within that 10-minute time frame. Now, this excludes accels, decels, marked variability, and any segments differing by greater than 25, so greater than your marked. So I know you guys, you all have basic, right? Yeah, okay. So you understand what I'm saying so far? Yeah, okay. All right. So when you're looking at your 2-minute window, there can't be any accels. There can't be, you have to look at your strict baseline when you're piecemealing that together. So bradycardia, anything less than 110, tachycardia, anything greater than 160. So you need to have more than 2 minutes of identifiable baseline segments, like I said, not necessarily contiguous, in any 10-minute window, or the baseline for that period is indeterminate. And you can have indeterminate baselines. Sometimes they're just all over the place and you can't piece them together. Or they might be, you know, 120 and then 150 and then, you know, 140. They might be all over the place. In that case, it's going to be indeterminate. And that can be your answer on the test too. So just keep that in mind. If that's the case, you can also go back to your previous 10-minute window for your determination of baseline. And that's in the real world. For the test, you're not going to have that luxury. The test is just going to give you a small section of the strip. And so you have to go by whatever strip they give you. So if you can't get your 2 minutes out of that, then it's indeterminate. Moving on to the next. So slide 86. Fluctuations in baseline fetal heart rate that are irregular in amplitude and frequency. And variability is quantitated as amplitude of the peak to the trough in beats. So absent variability is undetectable. It's a straight line. It's like you're looking at asystole. Minimal is greater than undetectable, so 1, but less than 5. So basically 1 to 4. And I guarantee you this in some way, shape, or form will be on your test. So the definition between absent, minimal, moderate, and marked. Moderate, where we all like to be, is between 6 and 25, and marked is greater than 25. And this is a really good picture, I think, of the variations in your variability. So the top, you have absent. You can barely see any squiggling whatsoever. I mean, there may be 1 or 2 spots where if you really blow it up and look at it, you might see a wiggle here or there, but the majority of it is pretty flat. And you can see the difference between that and your minimal. The next one down, you can really start to see a little bit more wiggle. And then your moderate, that's your 6 to 25, and then your marked, which you really can't determine at baseline with marked variability. Absolutely. Sorry. Yeah, no, go for it. How many adult code cards do we have? So, sinusoidal baseline. So this is visually apparent, smooth, sine wave-like undulating pattern in fetal heart rate. And the baseline with a cycle frequency of 3 to 5 per minute that persists for 20 minutes. So what does that mean? So you get this little like sawtooth pattern. If you take your block of 1 minute strip So just from one solid line to one solid line, you'll either have 3 of those little hills, or you could have like 5 of those little hills, but you'll see quite a bit of them. And if you do this long enough, you will see this, hopefully not for the real reasons, which is fetal anemia, meaning they're probably bleeding from like an abrupt or something, but you will see this, what we like to call pseudosinusoidal, which we're not supposed to say anymore, but we still say it. So if you give your patient Nubane, or even, some other medications, you'll see them go into this little pattern like that. And everybody that sees this, if you've been doing it long enough, we stop at the desk and we look at it and we're like, did you just medicate her? And if they say yes, we go about our business. If they say no, it gets our attention real quick, because that's someone that you're going to want to crash section. All right, so a true sinusoidal pattern is associated with severe fetal anemia, which may be caused by maternal fetal hemorrhage, fetal isoimmunization, so cells are attacking itself, twin-to-twin transfusion syndrome, or ruptured vasa previa. So the pseudosinusoidal are physiological states during drug-induced, caused by rhythmic movements of the mouth, or sucking. So honestly, you may see this if you haven't medicated them, they're not abrupting. Sometimes the baby will suck their thumb and it elicits this response, and it's the weirdest thing. But there's no real way of knowing that, but it has been seen on ultrasound. So non-REM sleep and the effect of certain drugs, particularly narcotics, like I said, you'll see this a lot with Nubane. But in and of itself, this is a very ominous sign, and you're going to want to crash that person real quick. I hope you never do either. I have, unfortunately, it didn't work well. But there again, you see it on the next slide. So, and that's really what it looks like. So it's kind of hard to see on this paper, but if you see where the numbers are on the left, and then you see that very dark line, and then you go over and you see another dark line. So you're 1 minute, you got 1, 2, 3, 4 hills in there. So they're like 4.5 really. There's your 3 to 5 undulating little waves. And like it says, most commonly associated with severe anemia. So probably an rupture, something like that. All right, so qualification of waveform. So this is for your abrupt, your onset to the nadir. So the nadir is your peak there, is less than 30 seconds. That's abrupt. That's where you're going to get your variables. Your gradual is onset to nadir, and peak is greater than 30 seconds. So that could be your lates, that could be your earlies, and the way that you're going to tell the difference is going to be in conjunction with the contractions. So very important. This is the first part of identifying what type of deceleration that you have. So the definitions for abrupt and gradual are embedded in the definitions of accelerations and decelerations, which we're going to get into in just a bit. Okay, slide 91. And this is a pretty good picture for that point. So the first one, you distinguished the onset of the waveform. Is it abrupt or is it gradual onset? So from the point where it very first starts to go down, so if you see the letter H there on the one on the left, that's right where your fetal heart rate starts going down. Letter K is the lowest point, so that's your nadir. Now, unfortunately, this one doesn't have the boxes like your strip would, so you can't really count boxes. However, I think it's safe to say that this is more than 30 seconds. You can see it would take up a few boxes. All right, and it's gradual. So gradual meaning more than 30 seconds. So 31 seconds and up. And in this instance, we're looking at it in correlation with the contraction. So you can see that it starts going down. So letter H again, as the peak of the contraction is going up, or the start of the contraction, letter C there, where it starts your peak, and then it ends, not ends, but the nadir, the lowest point, K, is right around where it ends. So you got your F there. And then over on the right-hand side, your H, so same spot again, where it starts to go down, is very abrupt. That is less than 30 seconds from the time that heart rate starts going down to the peak, to the nadir. So that is what you call abrupt. So if you have an abrupt one, that's automatically a variable. So you can see in relationship to the contraction, the variables don't necessarily matter in relationship to the contraction because it's whether it's abrupt or not. But it's important to remember that decels are defined by the onset and the timing in relationship to their corresponding decels. Do not assume that decels must be variables because she's not having a visible contraction. Assess for uterine activity by palpation and by talking with your patient. Ask her if she's feeling them. But like it says, assess the patient, not the monitor. So what I mean by that is if you're not picking up contractions and she's having a heart rate, if she's having decels, get your hands on her belly. And don't forget, anytime we touch a patient, please ask. But palpate her abdomen. And that's actually going to be on your test too. You need to make sure that you're palpating. Even if you get contractions on the monitor, you should always be going in and palpating them too. So if I'm doing Pitocin or if I'm going in there every half hour for whatever reason or taking a temp or whatever, anytime I go in the room, as long as it's not like every 15 minutes, but I'll go in there at least like every half hour to an hour and make sure I'm just palpating her belly. Make sure she's getting good resting tone. Make sure that you're picking them up. Especially if you're on Pitocin, it's really important that you pick up your contractions. If you've done everything and you still can't pick up your contractions, then you're going to ask for an IUPC. Do you guys know what that is? Intrauterine pressure catheter? Okay. We'll talk about that more later on too. All right, so accelerations. At 32 weeks and beyond, an acceleration is defined as an abrupt increase above the baseline with amplitude of greater than 15 beats per minute and a duration of greater than 15 seconds, but less than 2 minutes. And why less than 2 minutes? Because if it's more than 2 minutes, it's considered prolonged. Before 32 weeks gestation, sorry, somehow I just turned on my light on my phone. Sorry about that. Nope, still didn't turn it off. Here we go. Sorry. Before 32 weeks gestation, an acceleration is defined as an abrupt increase above the baseline that's greater than 10 beats and a duration greater than 10 seconds, but again, less than 2. And that's also going to be on your test. So before 32 weeks, they're only held to a 10 by 10 standard. After 32 weeks, they're going to be held to a 15 by 15 standard. And like I said, an acceleration lasting greater than 2 minutes, but less than 10 minutes is defined as a prolonged. If it's more than 10 minutes, then that's a baseline change. So, previously included a definition that stated once a fetus achieves 15 by 15, it should always be able to achieve a 15 by 15. So this statement has been removed due to the complexities involved in tracking this through pregnancy. So basically, if you had a 28-weeker who should be a 10 by 10 and they came in and they were giving you 15 by 15 axles, we would start holding them to that 15 by 15 expectation, so to speak. All right, 93. This one's a little fuzzy, but I think you can see it pretty good. So basically, this is this baby's got great variability. You could put that in any textbook of OB. She's having some contractions down there, but not too bad. We do see we have a little bit of a deceleration there. So if you look at that bright red line where the heart rate starts going down and you follow it all the way down to the bottom, you see your contraction is starting. If you go into the middle there where the numbers are, you could see that's your lowest point. That's your nadir. If you follow that in a straight line all the way down, you're going to see that's your peak of the contraction right there. And then if you follow the very next dark red line there, your heart rate's trying to come back up to the baseline there. Sometimes we do get these little overshoots or shoulders, as we call them. And we'll get into that in a little bit too. But if you follow that straight line all the way down, you notice that your contraction is ending. So first thing we're going to say, and when you're doing it, reviewing your strips on the test, you're going to look at everything. Okay, first thing you're going to look at, what's my baseline? Second thing, what's my variability? Then, do I have any accels? Do I have any decels? Yes or no? What are your contractions doing? Do you have any contractions? If yes, how far apart are they? Are you in tachysystole? You guys know what tachysystole means? Yeah, okay. All right, so if we're going to do this from the beginning, we have, and I honest to God can't even read those lines. I should probably know where that is. I'm going to say it's like 120. So we'll say 120, moderate variability. So my baseline is 120. I got moderate variability. I have positive accels because I don't know how many weeks this baby is, but whether it's under 32 weeks or over 32 weeks, I definitely have 15 by 15 accels. So if my baseline is 120, that's going well above the 135 that it needs to be and lasting for more than 30 seconds. So I have a couple of those. So I have positive accels. We do have one decel, so we're going to figure out what that is. Like I said, it's mirroring the contraction. So if it mirrors the contraction, those are usually early. And by mirror, I mean it starts when the contraction starts and it ends when the contraction ends. And the peak is usually right around the same time as the peak of the contraction. So we have moderate variability with an early accel. And this is actually still a category 1 strip. So even though you do have a decel in there, it's an early decel, and early decels are okay. So that is just head compression, and we will also talk about that in a little bit. Moving on. All right, early decelerations are defined as a gradual decrease and return to baseline associated with the contraction. The onset to the nadir and the offset occur coincidentally with the contraction, with the nadir at the peak of the contraction. And because of the importance and timing related to the uterine contractions, be careful regarding the use of a TOCO versus palpation or IUPC. So if you're not sure, you're not picking up your contractions, and you see that, what looks to be that decel on there, get in there and palpate. If you can feel it, then you can document that as well. So like I said, early decels are considered benign, and they are listed under a category 1 strip. So the physiology of early, so it's the pressure on the fetal head. So the head's getting squeezed or compressed. It alters the cerebral blood flow. That's why you get that decrease. It creates central vagal stimulation, which is blocked by atropine, and the deceleration mirrors the contraction that's causing the increased pressure in the fetal head. So basically, you're starting the contraction is the baby's coming down, and it's squeezing the head, and that's what gives you that vagal response, and they drop their pressure. Pardon me, as the contraction is released, it'll start going back up again. All right, and this is a good picture of it here as well. Sometimes they're not always picture perfect, as that last one that you just saw. The first one, if you'll look, it mirrors that contraction pretty well. The nadir is right in line with the peak. Second one, if you're not careful, you might think that's a variable, but if you look is where it really starts going down, it is 30 seconds. And some people might be, oh, no, the nadir is not with the peak. It doesn't have to be with the exact, like if you follow that straight dotted line, it doesn't have to be the exact peak of it. It still mirrors the contraction. It might be slightly off, but it's still within the peak. So within the top portion, that hill part. Okay. And sometimes you can have an early that's late to recover. And I think a lot of people get those confused, and they'll call them lates when they're not really lates. And I think I put a slide in there about that too. So we'll hit that at some point too. All right, 97, late decelerations. Defined as a gradual decrease and return to baseline associated with the contraction. It has a delayed onset with the nadir occurring after the peak of the contraction and the offset usually after the end of the contraction. So the beginning, the middle, the end are usually all after the contraction. So again, same thing, because of the importance and the timing related to the uterine contraction, be careful regarding the use of a TOCO versus palpation or IUPC. So we got to make sure you're getting your contractions, or you're at least palpating your contractions. Next slide. In hindsight, when I was putting this in, this was nice and big on my computer. Looking at it now in the screen that I have on, I can't see a blessed thing in here. But it's a good screen on the flow for the placenta and the umbilical arteries and the umbilical vein. I don't know how well you guys are able to see it, but anyway, the uteroplacental insufficiency results in decreased maternal fetal oxygen transfer. So this is just showing you how the flow can get interrupted there. All right, so the physiology of the decels, reflex. So decrease in blood flow delivered to the baby, such as with hypotension, maternal venous compression, uterine hyperstimulation, resulting in the inability to deliver enough oxygen to the baby. Or it could also be deoxygenated blood delivered to the baby, such as in the event of abruption, a maternal seizure, a PE, and asthma, resulting in a low PaO2 sensed by the chemoreceptors, which in turn trigger the baroreceptor response, which results in a slowing of the fetal heart rate. And a non-reflex, you have the deoxygenated blood, which is insufficient to support normal myocardial contractions, resulting in direct myocardial depression. And so here you see in this picture up at the top, you have the start of your contraction and the end of your contraction. And right when that heart rate starts to go down is at the end of your contraction. So it starts after the contraction's finished. You have the nadir, well after the contraction's finished, goes back up. So that's a late. And you can also see it in the bottom one too. So the reflex decels, such as the earlies, are triggered by the physiological reflex, so a head compression causing a vagal response. The non-reflective decels, like late decels, are caused by direct suppression of the heart muscle due to hypoxia, and they're less reliant on the vagal. So whereas you get your earlies from a vagal, these are not related to that. They are due to suppression of the heart muscle due to hypoxia. So have you guys ever heard of veal chop? Okay, good. I wish I thought, thinking about it now, I wish I thought to put one in there just for visual so you could see. But your late decels are due to placental insufficiency. So placental insufficiency, meaning your placenta is not getting enough blood, and that's why you get that suppression of the heart muscle, because if it's not getting enough blood, it's not getting enough oxygen, and that leads to hypoxia. So moving on. All right, so your variables, defined as an abrupt decrease in fetal heart rate below the baseline of greater than 15 beats, so meaning it has to go down for at least 15 beats and last for at least 15 seconds, but again, not greater than 2 minutes, otherwise you would have a prolonged. So when associated with uterine contractions, they may vary in onset, depth, and duration from the contraction to contraction, so they may not be uniform. They may be accompanied by other characteristics, the clinical significance of which requires more significance, and more research. We'll get into those too. So the cord compression leads to an increase in venous pressure. The pressure is sensed by the baroreceptors, which results in the vagus nerve stimulation, and the vagus nerve stimulation results in the decrease in fetal heart rate. So the fetus has built-in regulatory systems that allow for the maintenance of homeostasis. The variable decels are a demonstration of how the fetus responds to an increase in blood pressure by decreasing the heart rate to decrease the oxygen consumption and decrease cardiac workload. So if it decreases the heart rate, then it can conserve that oxygen and therefore not have to work as hard. And here you see some varying decels in various shapes and sizes. Usually your telltale sign for a variable is it either looks like a W or a V, and that's because it's so abrupt you're going to see that almost like a straight line down. And they can be a little wider like that first one. And then if it was, and I can't really see the numbers here, but I can kind of see the numbers here. If it was a drop of more than 60 beats lasting for at least 60 beats, so you have to last at least a minute, that would be a significant one. So, for example, I was at the desk the other day and someone had come out and they wanted to turn their Pitocin off because they had a couple of variables, but they, the fetal heart rate looked fine. Otherwise, variability was fine. Wasn't in tachysystole or anything like that, but she had a couple of small variables like the ones that you see over on the right here, and she wanted to turn them off because she had like 2 of them. And actually, you don't need to turn them off. if you look at the policy, you need to have significant ones. And she did not have significant ones, and they were just quick. It looked like little cord grabs, and that's a lot of times what you'll see with these variables, or they're just, something's going on with the cord. Either the baby is laying up against the cord, maybe the cord is compressed in between like their shoulder and the uterine wall, or it might be wrapped around the neck, or they might even just have it in their hand and they're just squeezing it. You never know. But it's usually due to the cord in some way, shape, or form. All right, prolonged decelerations, defined as a decrease of greater than 15 beats from the baseline that has a duration of greater than 2 minutes, but less than 10 minutes. Okay, so greater than 2 minutes is prolonged, whether it's prolonged accels, prolonged decels, greater than 2 minutes, but always has to be less than 10. Anything 10 minutes or longer is now a baseline change. So the onset may be gradual or abrupt, because you could have a prolonged late, you could have a prolonged abruption if you have what do you call it? Oh my God, I lost my word. Abrupt decrease. Again, the duration greater than 10 minutes is considered a change in baseline. Oops, sorry, I just did that again. I went to that last slide. I can't go back. Sorry. Oh, I don't know what the bottom. What did the last one say?
Must drop at least 15 or more beats per minute to be considered a prolonged.
Correct. So you have to. So when you're looking at them, they have to go down at least 15. If they're not down by 15, then it's not a variable. Okay. So prolonged decels, common causes, cervical exams, uterine tachysystole, bless you, cord entanglement, maternal supine hypotension, epidural, spinal, or paracervical anesthesia. The interpretation and management is difficult due to the variances in clinical situations and unpredictability. So bedside judgment is of the entire clinical situation is essential. So other causes, you can also see it from an FSC applied or maternal Valsalva maneuver. So whether she's coughing, sneezing, throwing up, maybe you might see that. Placental abruption and also maternal seizures. All right, and this is a good picture of a prolonged deceleration. And come to think of it, if you were here yesterday, was it? Yeah, yesterday, we had a young lady who had a couple lovely prolonged decelerations that bought her a ticket to the OR. So if you happen to see those, they were impressive. All right, and so again, you have your heart rate goes down in that like second minute box there, the second, those two big darker lines, it starts going down there. And each dark line to each dark line is 1 minute. So you got 1, 2, 3, 4, 5. You got about 5 minutes before it really starts even trying to go back up to baseline. And I can't even be sure. I don't even think it really goes back up to baseline by the looks of this picture. So that is therefore a prolonged, lasting greater than 2 minutes. All right, quantification of decelerations. So decelerations are quantified by the depth in the beats per minute and the duration in minutes and seconds. So decels are recurrent if they occur with greater than 50% of the contractions in a 20-minute window. Okay, so if you have a 20-minute strip and you have decels more than 50% of the time, that's considered recurrent. They're intermittent if they occur less than 50% of the time in that 20-minute window. It's not necessary to quantify all decels, but it may provide a clearer picture during the review process. So quantification should be included in verbal reports to providers or subsequent notes about these conversations. So you're going to want to chart it. You're definitely going to want to let your provider know. And the quantification can be provided in a range where the area being quantified is unstable. And you're going to want to know that definition about the recurrent versus intermittent, because that will also be on your test. All right, bradycardia and tachycardia. I am so sorry this is so tiny. It didn't look that tiny when I had it on my bigger screen. Hopefully you guys can see it okay. So bradycardia, less than 110 beats per minute. In the presence of bradycardia and in the absence of other blatant causes such as abruption, hypotension, assess for the presence of maternal autoimmune disease that may be associated with fetal heart block, such as Sjogren's, And that's just an autoimmune disorder where the cells attack itself. And review perinatal records when available for previous fetal heart rate. Tachycardia is greater than 160. Do not assume fetal tachycardia is normal in preterm fetuses. So again, they might be a little bit higher, but they should not be tachycardic. True fetal tachycardia is not commonly associated with moderate variability, accels, and or frequent fetal movement. They're commonly associated with maternal or fetal infection. So we all have seen it. You start having a kid that's starting to tack away, or maybe it's creeping up. And the first thing any of us old people are going to say is, did you check a temp? Because a lot of times, and we've had a few lately. Matter of fact, 2 in a row I've had where the kids have ended up either getting IV antibiotics or in one case going to Albany Med for sepsis. So something to be aware of. Progressive disruption of fetal oxygenation, fetal anemia, maternal hypothyroidism, fetal tachycardias, medications such as sympathomimetics or parasympathetic, caffeine, theophylline, cocaine, methamphetamines. And as with decelerations, the fetal heart rate is maybe further quantified in the range format of if the baseline is too unstable to identify. So again, assess your patient, not the monitor. All right, 109, uterine activity. So again, sorry, this is small. Uterine activity is assessed based on the number of contractions that are occurring in a 10-minute segment averaged over 30 minutes. So you got to look at your full 30 minutes. Normal activity of 5 or less contractions in a 10-minute segment averaged over 30 minutes. So tachysystole is more than 5 contractions in 10 minutes averaged over 30-minute period. And again, like I said before, you can use your tool to figure that out. It can result from spontaneous and or stimulated labor. So essentially, if you're looking at a 30-minute window, okay, so if you are looking for 5 and 10 minutes, that's literally half a 10-minute segment, right? So if you take 30 and divide it by 2, that's 15. So what that means is anything over 15 is considered tachysystole. You literally have to be contracting every 2 minutes, more than every 2 minutes to be in tachysystole. This one clearly is because you can see they are not getting a break. And sometimes you'll see a funky run or like 1, 2, 3, like you'll get these first 3 where you're like, oh, she's in tachysystole, but then you'll get like a minute or 2 break in between. And if you were to average that out, it actually would not be greater than 15. So you really got to kind of look at the whole picture, because sometimes you're like, oh my God, she's in tachysystole, and then you'll get like a 2-minute break. A lot of times you'll see that towards the end too, like when they're pushing, and I really think it's because they just need that break when you're pushing. So tachysystole greater than 5 contractions in 10 minutes averaged over 30-minute time period. That will be on your test. And again, like I said, that applies for spontaneous labor as well as, labor that's induced. 110, uterine activity. Management of tachysystole can vary dependent upon the clinical situation. So termination of cervical ripening agents or Pitocin should be based upon not only the contraction frequency, but also the fetal tolerance of the pattern. So even if you don't have tachysystole, if you have a kid that's on Pitocin and it's not tolerating it, and you need to turn it off. All right, in the presence of moderate variability and or accelerations and no other apparent change in the fetal heart rate pattern, monitor the tachysystole closely to see if it resolves on its own. Back in the day, we used to have a motto of PITS. This is a great slide right here. You are going to want to take a picture of this, put it in your phone, memorize this, however you got to remember it, because you will use this multiple times in your test. So if you have a category 1 strip, you have normal fetal acid base status, you have a well oxygenated fetus again at the time that you're observing the strip. Category 2, you have maybe indeterminate baseline, a compensatory response. And category 3, that is abnormal, and you have an acid base status situation going on there. So that's going to be on your test in some way, shape, or form. So if you know the difference between category 1, category 2, and category 3 and what's going on, you should have no problem getting the question right. I do believe I saw a question on there one time. It had minimal variability, so automatically that put it into category 2. And the easy way to remember that, if you know what a category 1 is, you know what a category 3 is, everything else is category 2, because category 2 is the hardest thing to remember. There's so many different components to it. But if it's not a 1 and it's not a 3, it's a 2. 3 is very easy to memorize. 1 is very easy to memorize. So the fetal heart rate was like, I don't know, 140s, 150s. It was completely normal as far as that goes. So you had a normal rate. However, what wasn't normal was the fact that it was minimal. So like I said, that's what put it into a category 2. But it's, even though you can see what the rate is, they are still calling that indeterminate as far as listing it into a category. So that's something that can throw you off. I feel like that's a tricky question and maybe not a fair question, because your answer might be, look at this strip. Again, you have a heart rate that's in the 140s, but it's minimal. No accels, no decels. Everything else is fine with it. And you might be, the answer might say, I think it was something like, which one is right, A, B, or C? And it was A, it was normal, B said intermediate or indeterminate, and C said abnormal. And those were the only things you had to go by. So if you weren't careful, you'd be like, well, normal, the baseline is normal. So it's not an indeterminate baseline. You would think they were talking about baseline. And actually the answer was indeterminate because it was a category 2 strip. So just be careful, really read the question, really try to determine what they're asking you for. And that's where, if you're not careful and you rush through the questions, you might be like, oh yeah, that's normal. And you'll pick the wrong one. So just be careful with that. All right. All right, so for category 1, which is considered normal, this includes all of the following. So you have to have a normal baseline, and normal baseline is between 110 and 160. You have to have moderate variability. There can be no late or no variable decels. You can, however, have an early deceleration, or you don't have to, but that is the only one you're allowed to have. And you can have accelerations, but you don't have to. For a non-stress test, yes, you need them. For a category 1 strip, no, you do not. So you can reliably rule out metabolic acidemia at the time the tracing is being reviewed. It does not preclude the possibility of pre-existing neurologic injuries, such as those related to anomalies in development or those acquired by an unknown hypoxic event that occurred during the antenatal period. Remember, I told you could have something that happens, some sort of insult, and the kid will compensate, and then you'll put it on the monitor and it looks fine. And then it's born and all of a sudden it's not fine. So when you're looking at it, but because the fetal heart rate regulation is primarily driven by the brainstem, a fetal heart rate tracing may be category 1, but the neonatal infant may later show signs of compromise due to a hypoxic insult or developmental abnormalities in other areas of the brain during fetal development. So these are the kids that do well when they come out, and then all of a sudden you cut that cord and they go to shit real quick. So category 2, and this is what I was talking about, your indeterminate. So examples of this would be, you can have moderate or minimal variability with recurrent lates or variable decelerations, moderate or minimal variability with prolonged decelerations, absent variability without late or variable decelerations, because if they have absent with, then that's, especially recurrent, that's going to put you in category 3. Bradycardia with moderate variability, tachycardia with minimal or moderate variability. So the fetal status is indeterminate and requires ongoing assessment and or interventions depending upon the known contributory factors. So interventions for decels will be determined by the type, the size, and the frequency of decels. So interventions for minimal variability with no known cause will vary from that with known causes. Like if you have someone who's on MAG or you gave them Nubane, you're going to know why you're a category 2 all of a sudden. where in other cases you don't. So you really got to determine what your causes are. So if you're having some variables, what's your answer to that? Your answer to that is get her off the cord. You're going to do maternal positioning. You might even do a fluid bolus. If we were in a lot of other places other than here, you might even do an amnio infusion. And if I haven't already said it, I'll say it about 10 times later on, now that we're getting into strips and stuff. Just because we don't do it here doesn't mean you're not going to be tested on it. So amnio infusion is a great way to try and treat your cords, your variables. So, and again, that's going to depend upon positioning of the baby and stuff like that. If they're too well engaged into the pelvis, she's like 8 or 9, maybe that's not the best time to do it. If she's 2, 3, yeah, sure. Okay, and here we have category 3, which is your abnormal. So either absent variability with recurrent lates or variable decelerations or bradycardia. So you have to have absent variability with one of those 3 things: recurrent lates, recurrent variables, or bradycardia, or a sinusoidal pattern in and of itself. So if you just have a sinusoidal pattern, that's automatically a category 3 strip. If you have absent variability, you have to have either recurrent lates, recurrent variables, or bradycardia to be listed as category 3. And if you have a category 3, then you are looking at imminent delivery immediately. So usually 9 times out of 10, that's going to be a C-section. But fortunately for us, knock on wood, only a quarter of the category 3 tracings will have metabolic acidemia. So doesn't mean they don't happen, but that's why if, you see a sinusoidal pattern, hopefully 9 times out of 10, it's because somebody was medicated. All right, moving on. So this is your management algorithm for your fetal heart rate tracings. And you can see your different categories there: category 1, category 2, and category 3. So this is your management for each one of the categories. So if you have category 1 strip, keep doing what you're doing, routine management. And this is according to ACOG, so the American College of Obstetricians and Gynecologists. They're, along with A1, one of our guiding benchmarks that we use. Category 2 strip, so you're going to evaluate and surveillance. Confirmation tests, for example, like I said, if you have minimal variability, not with a decel, you can go in and do a scalp stim or some vibroacoustic stimulation, see if you can elicit that accel response. All right. So if you do get an acceleration or moderate variability, then you're going to go back to your category 1 measures and you're just going to continue to monitor. Or you might have to do some intrauterine resuscitation measures. It depends. If you have absent fetal heart rate accelerations after you've tried like a scalp stim or whatever, and you are still having minimal variability, then you're going to try your intrauterine resuscitation measures. So, all the things, your fluid boluses, your change your positions, if it gets bad enough, you're going to start O2, all the different things. So if it's still not improved, and it progresses to a category 3, then you're going to consider immediate delivery. And then your category 3, you're going to start your intrauterine resuscitation measures immediately, and you're going to prepare for a delivery. And if not improved, you're going to consider prompt delivery, which we were already considering anyway. So there is no other way around category 3. Category 3 means you deliver now. So the only thing is, if you don't have a provider, then you're just going to keep doing your intrauterine resuscitation measures until you do have one. Having said that, say you had somebody with a category 3 and she's, I don't know, long, thick, and closed, or 1 centimeter, or whatever the case may be. A lot of times anesthesia, if we're doing a section for whatever else, failure, trypographs, whatever the case may be, they get kind of touchy if you move them into the operating room without them being here. If you have a category 3 strip, if you have a cord prolapse, if you have sinusoidal, especially like an actual standalone sinusoidal, you get that patient into the OR as soon as possible. It doesn't matter if anesthesia is here or not. You're trying to save as much time as possible. So I've actually done one case on somebody that had a category 3 strip that anesthesia was not in house and the provider wasn't in house. The provider got there first, and we literally started with lidocaine, and they just inject, cut. And unfortunately, in order for lidocaine to work, you really got to give it a good 5-10 minutes. And there were no 5-10 minutes to be had. So she felt every single solitary thing, but we did not have the luxury of waiting for anesthesia to get there. So we had to do what we had to do. Unfortunately, the baby passed anyway. But so she was really traumatized. But you got to try, you know? So my point is, don't waste time getting into the OR. Just if you have a category 3 strip and she's not fully dilated, then go. If she's fully dilated, there's a small chance you might be able to deliver. Do you know what I mean? Like, you got to push now. Do you know? But other than that, if that kid's not right there, you're going to the OR. Okay. I really apologize for this. This one's super hard to see. And I fear the next one's going to be even worse. So this is your management for category 2. So your moderate variability. I can't even hardly see this really. So significant decels with greater than 50% of the contractions for an hour. If yes, you're going to go down your cascade down to the left here. Are you in the latent phase? If you are, then you're going to go to a C-section. If you're in the active phase, pardon me, is the labor progressing? If no, you're going to go to a C-section. If yes, then you can continue to observe for a little while. If you're in this second stage, you're actively pushing and she's making progress, like I said, great. Keep going. If not, then you need to consider a C-section or an operative vaginal delivery at that point, meaning, you know, you can do an appease, you can put a vacuum on, you can do forceps. Again, forceps, knock on wood, since Dr. Bloss has left, is not something that we do here anymore. But, you know, new doctors can and will come, and that may be their preference. So, and I've said it before, I'll say it again, just because we don't do it doesn't mean you won't be tested on it. So, all right. So if you are asking yourself at the top again, if you have moderate variability or accels, and the answer is no, then are they significant decels with 50% of the contractions for more than 30 minutes? If yes, again, you're going to consider C-section or an operative vaginal delivery. If no, you can observe for an hour. If it's a persistent pattern, again, C-section. If not, you can manage per the algorithm. So, and you know, kids can go in and out of algorithms. They can go from category 1 to category 2. Usually if they're in category 3, they don't necessarily come back from category 3, but the other two, yeah. All right. I'm not even going to try this one. You can't even read it. I apologize profusely. But category 3, so basically you have, like I said, your absent variability with either recurrent lates or variables or bradycardia, or your standalone sinusoidal. And so you're going to do your assessments and your interventions and your considerations as opposed to just the characteristics of your fetal heart rate tracing. So that includes your ongoing labor interventions to maximize uteroplacental blood flow and attempt to prevent the progression of the fetal compromise. And your category 3 tracings, like I said, are categorized by either absent baseline variability and the presence of recurrent lates or recurrent variables and bradycardia or sinusoidal in and of itself. So a prompt assessment of the fetal heart rate tracing and the mother's condition is of the utmost importance. This is one of the ones where you're actually going to apply oxygen. We don't really apply oxygen as much as we used to. It used to be anytime you had a decel, you were going in, you were flipping the patient on her side, and you were automatically putting oxygen on. We don't really do that too much anymore. However, this is one of the times you would absolutely, you know, move her, get her on her side, give her oxygen, give her a fluid bolus. Depending on why you have that category 3, you might even get her in like hands and knees position, or, you know, a reverse Trendelenburg position if she has a cord or something, like whatever the case may be. If you have Pitocin going, you're going to stop that. If you have cervical ripening, you can either take it out, or, you know, if she's taking PO, Cytotec, then unfortunately you can't really take that back. But you can certainly flood her with fluids and hope that that helps. And one quick rule of thumb, if you are putting oxygen on your patient and she's so bad that you're putting oxygen on her, then if you have Pitocin going, you need to have the pit off. That's going to be very hard to document or to argue in a court of law why you have Pitocin going if you thought she was bad enough to put Pitocin or put oxygen on her. So just keep that in the back of your mind. Again, treatment of maternal hypotension. So a lot of times we'll see that when patient gets an epidural and then all of a sudden her heart rate, or excuse me, her blood pressure drops, and that's going to affect the baby. So a lot of times I'll say if you can fix the blood pressure in mom, you will fix the baby. So you can just start by fluid bolus, and then don't forget, get on the horn real quick, call your anesthesiologist back. If you don't already have ephedrine ordered, get it. Usually they'll come up and give it, but sometimes, I mean, we can give it, but you do kind of need an order for it, and unfortunately we can't really override that in the Pyxis. And then your emergency C-section delivery, of course, prompt surgical delivery will hopefully improve the fetal outcome. So in summary, the category 3 fetal heart rate tracing is a serious indication of fetal distress that requires immediate attention and intervention to ensure the safety of both the mother and the baby. And again, I apologize that picture is not better. Maybe you guys can see it. I don't know. I hope. But I think at this point, you know what to do with it anyways. According to this picture, it looks like there's a lot of ways to go, but there's really not a lot of ways to go. You're going to do all your intrauterine resuscitation measures. You're going to get a hold of your provider. You're going to make all the phone calls. I would be getting my operating room ready, even if you haven't even already talked to your provider. Point in case 2 weeks ago when that girl came in hemorrhaging, and I literally just said to Jamie, I said, have Carol open the OR. And she says, do you mean pull? And I said, no, open. So to me, and Jamie and I have been working together for 20 years, so I wouldn't say that to you. I'd be like, have Carol open the operating room. Then I want you to call Dr. Clements. Then I want you to call the nursing supervisor, get the team in here, do this, do that. But we've been working long enough together. If she says pull and I say no, open, then she knows we're going to the operating room, and she knows what that means, and she knows who she has to call and what has to be done to get that done. And I bring that up because somebody actually said that to me the other day, like, how did you know? So that's how. But anyways, and there's no harm in getting an operating room ready. I would rather have it ready and not need it. We've done it many times before, than need it and not have it. So, all right, moving on. Intrauterine resuscitation, indeterminate and abnormal tracing. So the goal is to promote oxygenation and improve blood flow. So, for use in the presence of minimal, not a sleep cycle, or medication-induced or absent variability. So remember what I told you, babies are entitled to sleep, but not for too long. So if you're worried about it, like I said, scalp stim if you're not in the middle of a decel, or you can do vibroacoustics, you can do fluids, you can change positions. Recurrent lates, variables, or prolonged decelerations and bradycardia. So with things like that, you can consider pushing either every other contraction or even every third contraction. All right, 119. So the interventions include lateral positioning or pushing. Lateral positioning, either on your left or your right side. IV fluid bolus. Correct your maternal hypotension. So all the things we were just talking about. Stop or remove any uterine stimulants, whether that be Pitocin or prostaglandins, whatever the case may be. Amnio infusion, again, like I said, I know we don't really do that, and I'm going to get into that in a little bit here. But during the first stage of labor, that's good. Again, second stage of labor, not so much, because the head's going to be too well applied and you're not going to be able to get the fluid back. So alter maternal pushing efforts, like I said before, either every other or every third. You can apply oxygen at 10 liters per minute via non-rebreather. That's also going to be a question on there when you apply oxygen 10 liters per minute via non-rebreather. Which is funny because in my outside world as an EMT and a firefighter, we do 15 liters per minute via non-rebreather. But here I have to remember it's only 10. Same as a baby. That's how I remember it here. And medications, you can use your sub-Q terbutaline or IV push ephedrine. So again, the terbutaline is your tocolytic. That's going to stop, hopefully, your contractions. So if you need to buy time until the provider or the surgeon can get here, you have to have an order for it. But certainly 0.25 of a turb sub-Q will hopefully help. In addition to all your other interventions, of course, because a lot of times they may or may not want you to push turb. Well, not push it, but inject it. And then your IV push ephedrine. So that's when you have your hypotensive patient and now it's affecting the baby. And that's usually going to come from anesthesia. And, you know, status post your epidural, and you're just going to have them come up and either give them 5, 10, maybe even 15. Who knows? Ephedrine. It depends. And it also depends on how symptomatic your patient is too. You know, some people live in low blood pressure ranges and they may not be symptomatic at all, but keep an eye on it, because if it starts affecting your baby, then you have to correct it. All right, repositioning, when to do it. So the fetal heart rate pattern suggests a decrease in fetal oxygenation, a decrease in uteroplacental perfusion, umbilical cord compression. So the maternal status suggests hypotension, and the uterine activity is excessive. All right, IV fluid bolus, when are we going to do that? When the fetal heart rate pattern suggests a decrease in oxygenation as well, maternal status suggests hypotension and or dehydration, and the uterine activity is also excessive. Correct maternal hypotension. So first thing you're going to do is increase your IV fluids. So a patient with chronic hypertension and or pregnancy-induced hypertension may suffer from hypotension symptoms along with their fetus while their blood pressure is within normal limits if there's been a rapid or significant change. So if she's been living in the 170s over 90s to 100 and she gets an epidural and all of a sudden she's like 130 on 70, we're like, woohoo, that's fabulous. But now all of a sudden she's lightheaded, dizzy, nauseous, she doesn't feel good, the baby's heart rate's dropping. Just because that's a normal tensive blood pressure in our world, that's not where she's been living. And so she might feel the effects of that, in which case you're going to have to fix it for both her and the baby. And so what can you do about that? Maternal position change, your IV fluids. And again, like I said, call anesthesia if applicable. I mean, if it's not an anesthesia problem, you know, you're not calling anesthesia when they don't have an epidural or a spinal or whatever the case may be. Oxytocin. All right, safe practice strategies. And you really do need to know your oxytocin checklist for your test too. So we used to have it, and I don't know if we still do, but we might, if you look out in the labor room, in those little cubbies, we have a lot of papers. So when stuff goes down, when the computers go down, we can just pull them. But somewhere around there, and it's also in Epic, but it's a little harder for me. Maybe it's just because I'm used to paper to see it in Epic. I like having it right in front of me, but there it tells you the criteria that you have to meet in order to continue your oxytocin. So your oxytocin checklist. So you have to meet certain criteria. If you don't meet it, you either can't increase it. So like going back to a while ago when I was talking about the person that had the variables, I'm like, no, actually, I wouldn't increase it, but you don't have to turn it off. So certain things like that. You may not have to turn it off, but in certain instances, you can increase it. And you should be checking that every half hour as long as the pit is on. All right, so these safe practice strategies, so standard order sets and protocols are based on pharmacological and physiological evidence. So you're going to start at 1 to 2 milliunits per minute and increase by 1 to 2 milliunits per minute, no more frequently than every 30 to 60 minutes based on maternal fetal response. So just because you can go up every 30 minutes doesn't mean you should. You're always going to want to check and see what your mom and your baby are doing. So too much, the oxytocin receptor sites will be desensitized. They can get oversaturated. They frequently resolve by rest periods and IV fluids to allow the sites to resensitize. So they become overfloated. So a lot of times, rule of thumb used to be if you oversaturate your receptor sites, say you're on 10, for example, a pit, even though that's not really a lot. But for example, say you're on 10, actually, say you're on, when we really used to go up to really high numbers like 40. Say you were at 40 and just nothing's happening. Your patient's still not in active labor. So clearly, with the pit being at 40, something should be going on. So at that point, if nothing's still going on, she's probably oversaturated. So a lot of times what we would do, we would literally just take it all the way back down to 10 and then slowly work our way back up again. So give those receptor sites a chance to relax. Another thing we would do is we would pit them all day and all night, and if that didn't work, we would send them home, have them rest for a couple of days, and then come back a couple of days later and try again. And a lot of times that would work. So sometimes they just need that time. This can be associated with coupling patterns too. So a lot of times you see that contractions, one right after another, they're together. They don't even really come all the way back down. It looks like two little humps they're coupling. Or even tripling. All right, oxytocin and tachysystole. So oxytocin-induced tachysystole with a category 1 fetal heart rate. So you're going to do your left lateral position or right lateral. It doesn't really matter. Remember, that was a test question. Left or right, doesn't matter. IV fluid bolus of at least 500 mLs of LR. If it's not resolved in 10 to 15 minutes, decrease your oxytocin by half. If tachysystole continues, and again, this is for category 1 strip, if the tachysystole continues after 10 to 15 minutes, decrease the rate or discontinue the Pitocin until the uterine activity is less than 5 in 10 minutes. So oxytocin-induced tachysystole with a category 2 or 3 strip, you're going to discontinue the oxytocin altogether. You're going to do your maternal positioning on your sides. You're going to start your fluid bolus of at least 500 mLs of LR. You're going to consider your oxygen at 10 liters per minute via normal breather. And you're going to discontinue that as soon as possible because, again, it's not controversial, but it's not as recommended as it once was. And this is a place where you can consider your tributaline, especially if you're in a category 2 or 3 strip, especially 3. So, again, that's something that you're going to need in order for. So, if you are thinking you have an abruption, absolutely no tributaline, because that's just, you want the contractions in that case. You want that uterus to clamp down to control the bleeding. And if you relax it, she can bleed out. All right, next one. Oxytocin and tachysystole again. So resume the oxytocin if less than 20-30 minutes and the fetal heart rate and contraction pattern are normal. So you can resume your oxytocin at no more than half the rate than that caused tachysystole. So, for example, say you were at 20 of Pitocin and all of a sudden you started getting tachysystole and you turn it off, or you even cut it in half, but say you turn it off and now 20 minutes have gone by and you want to restart your Pitocin. If it's only been 20 minutes and you have a category 1 strip and everything looks fine, you can restart again at half the rate. So if you are at 20, you can start it at 10. If you were at 10, you can restart it at 5. So whatever the rate is, half it. If it's been more than 30 minutes, you have to start all over again from 1 to 2. All right. Now, if more than 30-40 minutes and the contractions, like I said, are normal, you can restart at the initial dose. If it's not normal, then you're probably not restarting it because you still have to meet those measures to where you can start your Pitocin. And remember, before we start any kind of Pitocin, you're going to need a 20-minute reactive strip before you even start it to begin with. So, all right, and here we're going to talk about amnio infusion a little bit. So when is it done? So if you have recurrent variable decelerations during the first stage of labor that have not resolved with position change, and you don't do them for late decelerations, you don't do them for active pushing, and you don't do it for meconium. So we're not putting it in there to wash out the meconium, so to speak. So amnio infusion is always good for cord involvements such as variables. And like I said 100,000 times, just remember, just because we don't do it doesn't mean it's not going to be on your test. So the amnio infusion is a procedure where fluid, and it's usually normal saline, although you can use LR, is added into the amniotic sac to increase the fluid volume. So it's commonly used to relieve cord compression. Often when the fetus shows signs of distress, it's due to low amniotic fluid, and it's performed by inserting a catheter into the uterus or through the cervix, or even sometimes you can do it transabdominally through with an ultrasound and a needle. Although I would not do that, but it can be. Your provider will determine if it's necessary. Our providers here don't usually do it. We do not, or we no longer have a policy, and you do really need to have a policy, although St. Peter's does do them. So we've talked about getting it back here. We'll see. It's usually due to signs of fetal distress like repetitive variables, and the fluid needs to be warmed. So believe it or not, we actually do have a fluid warmer. It's actually a blood warmer, but technically a fluid warmer. There's one in each OR, and surprisingly, not a lot of people even know that we have it. So If you want, sometimes I'll show you where it is, but if you go over to our main OR, if the dad is sitting here, and I'm going to describe this so Shelly knows what I'm talking about because I'm taping this for her, which is why I wrote this out so I could actually say it right. All right, so if you're in the main OR and you're standing over by the baby warmer and you're looking at anesthesia, we usually have dad sit down on the one side of mom's head. There's a pole there that they clip the blue drape onto, right? On the other side of the mom's head, there's another pole, and anesthesiologist will clip the other side of the blue drape to it. That pole has a fluid warmer on it. So a lot of times we don't see it because it's right underneath the blue drape, but there's a fluid warmer on it. And there also is one in the other operating room down here in the labor room as well. So a word of caution about the amnio infusion. And that would be something that you want to provide earlier in labor, especially if the head is very well engaged or applied. You're not going to get a lot of that amniotic fluid back as it's leaking out, and your uterine tone might rise. So you got to be careful with that. So you don't want to do an amnio infusion. We don't do them on our unit, but they do them at St. Peter's, like I said. We may in the future. Like I said, we've discussed it before. I used to do it at St. Mary's, although we never really did them a lot. So I've only done a couple, and that was 150 years ago. So I would need a refresher course myself. I understand it. I understand how it works, but yeah. So you can alter your pushing efforts if that's when the variables are occurring or you've been pushing. You can check your patient because you've had some variables or decels and you find that there's a cord. You're going to need to elevate the presenting part away from the cord and move towards an operative birth, meaning a C-section. So you got a cord. Put her in Trendelenburg. A lot of people surprisingly don't do that. And I don't know why. It'll help slide and take the pressure off that cord. So you could put them in hands and knees. What was the name of that procedure? Who took spinning babies with me? You? Remember when you get down on your hands and knees and your ass is way up in the air? Forward leaning inversion. That's it. Yeah, you can do that. I wouldn't do that. Like I would do it in the bed. I wouldn't do it on a chair. But like if you're trying to get the head off the cord, that's a good thing to do. So I would do that, like get her in a hands and knees position, drop the foot of the bed, put her hands down and get her butt up in the air. But 9 times out of 10, I got her on her back. I'm just putting her in Trendelenburg. It's 10 times easier. Just put her head down, feet up, and go. All right. Moving on. Second stage of labor. All right. So active pushing is the most physiological stressful time of labor for the fetus. So we're trying to avoid tachysystole. We're going to discontinue or decrease the oxytocin based on the fetal heart rate pattern. And actually, Pitocin labor is usually self-sustaining once they hit like 7-8 centimeters anyway. So there really shouldn't be that much of a need for it. Every once in a while, you may have somebody stall out, but for the most part, especially if I have somebody who's being induced, they don't really want to be induced. They hate the thought of Pitocin. Oftentimes, I'll say, just let me get you to like 7 or 8 centimeters. If I can give you to 7 or 8 centimeters, we can turn it off and you should be able to go by yourself. Do you know what I mean? Especially if her water's broken, things like that. So if the heart rate does not recover between pushing and contractions, what are we doing? So we're going to discontinue pushing temporarily, maybe give her a break. You can push with every other contraction. You can even push with every third contraction. You want to maintain a stable baseline heart rate. Oxygen, when do we do it? So if you have minimal variability, especially in the absence of identifiable causes such as a deep sleep cycle or medication administration. So if you gave her Nubain, you kind of know why you have a category 2 strip. If you had a great strip the whole time and all of a sudden it went to a category 2, again, like I said before, the baby might be sleeping. Give it 20 minutes and see. Babies are entitled to sleep. But short of those sort of things, if you're having recurrent lates, recurrent variables, prolonged decelerations, bradycardia, those are the kind of things you're going to want to apply O2 for. And remember, it's 10 liters per minute via non-rebreather. All right, so when oxygen is chosen for intrauterine resuscitation, it's assumed that other sources of potential fetal physiological stress have been minimized. So, like I said before, oxytocin should not be infusing at the same time that you're giving oxygen. Oxytocin should not be infusing at the same time that you have PIT going. So if your PIT's on and you're putting on oxygen, PIT needs to go off. Oxygen therapy via the mother to the fetus can be beneficial in increasing fetal oxygen levels. Prolonged use should be discontinued until more data is available regarding the risk to the mother and the fetus, because there has been known risks with prolonged oxygen with babies. So that's why, part of the reason why we're kind of hesitant to use it. But there is a time and place for everything. So if you need it, you need it. So and once again, it can be inferred that in the presence of moderate variability and or accels, you can rule out metabolic acidemia, and therefore oxygen is not indicated. So again, you've heard me talk about metabolic acidemia, probably to exhaustion at this point, but there's reason for that because it's going to be on your test. All right, fetal stimulation. So fetal scalp stim, we've talked about that before. Vibroacoustic stimulation, I've talked about that, both of them a couple of times, but just a review. So that may be applied when assessing the fetus to rule out the presence of metabolic acidemia. So the stimulation should be applied while the fetal heart rate is at baseline. It should not be applied during a decel. Okay, that's very important. The production of an acceleration is typically associated with a non-acidotic fetus, meaning the pH is greater than 7.19 and a normal oxic central nervous system. So again, remember when I told you if you elicit that accel, you can be pretty sure that your pH is at least 7.19 and normal is 7.2 on the low end. So I remind you that the test is looking for nationally accepted and recommended practice, not what you do in practice per se. So don't answer something wrong just because you disagree with the practice. So just keep that in the back of your mind, because sometimes we do that. Okay, so another review question. Maternal oxygen for intrauterine resuscitation should be given at how much? 8, 10, or 14 liters? That's going to be 10 liters per minute. Again, like I said, be a non-rebreather. Just like the babies, you can keep it in mind like that. Another review question. Fetal scalp stim is appropriate in the context of what? Prolonged decels, minimal variability, or bradycardia. And remember, I said that was minimal variability. Just think of your sleeping babies, because they will be minimal, but that's not necessarily a bad thing. They might just be sleeping. You never want to do it in bradycardia. You can vagal them. Same thing, prolonged deceleration. They're already struggling. You don't need to activate that vagal response and make it worse. Okay, velamentous insertion and vasoprevia. We touched on this ever so slightly, way in the back in the beginning. So this is just a little bit more in depth. And hopefully you don't see really either one of these, but you will if you do this long enough. You'll see a few of them. I was going to say, we just had one not that long ago, which is kind of weird. But you know what? The longer I do this, more I've seen things more now than I've ever seen before, like in my past 25 years combined. So I swear this stuff has to do with COVID. I'm convinced of it. Anywho, velamentous insertion. So the umbilical cord is attached to the amniotic membrane in part or in whole and not into the placenta. So the vessels are traversing the membranes and they're at risk for rupture or hemorrhage with AROM. So remember I told you, you go to breaker water and you see all that bleeding, you're going to see lots of decels, and that's going to be a big problem. So the vasoprevia is the placental blood vessels lying between the fetal presenting part and the cervical ossal opening. A ruptured vasoprevia, so the initial fetal tachycardia, bradycardia, your sinusoidal fetal heart rate pattern, it has a 60% mortality rate, so really super high, and you're going to see that bright red bleeding. All right, so next slide, abruptio placenta. So the risks are a prior history. So the recurrence has a rate of 5 to 15% if they've had one before. If they've had 2 abruptions before, they jump all the way up to a 25% chance of a reoccurrence. So that's pretty high. Hypertension is another risk factor. That's again why we don't like to see these, and boy, are we getting more and more of these preeclamptic patients, so many more. Everybody's just hypertensive. So that's why we don't like, those are ones that you're not going to see somebody with either PE or chronic hypertension go to like 40, 41, 42 weeks. This is why. Cigarette or cocaine use, because you're going to get that calcification of the placenta. Blunt force trauma, car accidents, things like that, maybe domestic violence, things of that nature. And the diagnosis is by clinical findings. So you have increased uterine activity. So that abdomen's going to be rock hard. They're just not getting any resting tone. You'll see change in fetal heart rate. Their uterus is going to be rigid. Klein-Howard-Becky is a test that we sometimes do where you look at the smear in the maternal blood to see their fetal cells in the bloodstream. You'll see it a lot in the Rh negative moms to determine the appropriate dose of RhoGAM to be given, actually at 28 weeks and at postpartum. Sometimes, although not so much anymore that we have Epic, but sometimes they used to call us up a lot and be like, when was the last time she got RhoGAM? So, and that can have issues with your Rh incompatibility issues with subsequent pregnancies where it'll attack the subsequent pregnancy. So even ultrasounds will miss a good percentage of small abruptions. So the best course of action is for them to stay on the monitor for a while because the baby will let you know if something's going on and if there's trouble. So just time and monitoring, and the management will depend on the severity and the gestation. So next, uterine rupture. So you're going to have, again, abnormal fetal heart rate. Most common sign is 70% of the cases is your abnormal heart rate. You're going to have recurrent lates, variables, or prolonged decels and or fetal bradycardia. And these are the ones where you literally just see them and they just drop off the monitor. It'll look like a ski jump. Like you'll be going along normal and all of a sudden the heart rate just drops right off. And so, those are the ones you really want to get on top of too. So there's going to be a loss or inability to attain uterine activity by electronic fetal monitoring, especially if previously viewed. So if you can see it before, you might not be able to see it anymore. And that's because, the baby, if they were well applied before, they might not be well applied anymore. You're going to have loss of your fetal station because now they're filling up with blood. So you get that new onset of intense maternal pain. And that's one great way of how you can determine like a rupture from like a previa or something. You have that pain and it is incredibly intense. So, check for vaginal bleeding. And these people are going to need to go to the operating room incredibly quickly. All right, so medications. This is a little chart that you're going to want to commit to memory. All the narcotics, as I'm sure you've seen before in practice, will decrease your variability and decrease your ACT cells. Statol we don't really use anymore. We used to use Statol all the time, and now we use Nubane, which Nubane isn't really on this list, but it's right there with the Statol. They can cause that transient sinusoidal or the pseudosinusoidal. So remember I told you, you have that little undulating strip and somebody walks by and they may stop dead in their tracks and they'll be like, did you just medicate room 5? Yeah, okay. And they'll keep moving on because you'll see that. So you'll see it with MAG, you'll see it with, Nubane, all these other medications. So again, cocaine can decrease your variability. MAG sulfate definitely decreases your variability. And you also get a really flat looking strip and you might not necessarily get your 15 by 15 ACT cells. Betamethasone can decrease your variability. And you might also see if you go into triage and someone comes in for betamethasone, that is a shot that has to be given every 24 hours times 2 doses. So they may come in at 1 o'clock in the afternoon and then the following day they'll come in at 1 o'clock in the afternoon to get their second dose. When they come in for that second dose, you put them on the monitor, you might see some decreased variability. So, and I think if I remember correctly, there was a question about at least 2 of these on the last exam. I think it was MAG and betamethasone. So Tributaline will cause an increase in baseline. And again, Tributaline, I always tell people what it's going to make them feel like if they come in and get TURB. Maybe they're, 32 weeks or whatever, and history of preterm labor, and they might be starting to do something. You give them some Tributaline. I always forewarn them. It's going to make your heart race. It's going to make you feel anxious. It's going to make you feel hot. It's going to make you feel, like your heart's pounding onto your chest. Always give them those forewarning signs. And then the zidovudine, that's an HIV drug that, knock on wood, we don't see here. However, like I always say, this is an obstetrical emergency room, and you never know what's going to walk through the door. So, point in case, we had a patient that wasn't supposed to come here the other day, was 34 weeks, was specifically told to go to Albany or St. Peter's, and she decided she didn't want to do that, so she came here instead. So, just because they're not supposed to deliver here doesn't mean they won't show up, whether you tell them to or not. So, and you also, Route 7's busy, especially if you got leaf peeping season or ski season. People are going back and forth. There's accidents or something happens and they go into labor. People are going to stop here because it's the closest hospital. So you never know what you're going to get. All right, the equipment. So Doppler ultrasound. So bedside monitors use autocorrelation. So it compares the successive reflective waveforms at many points. A handheld Doppler uses ultrasound to detect the motion of the heart wall valve. The fetal scalp electrode converts the fetal ECG to FHR by measuring the consecutive R-to-R intervals. And that was on a test. So fetal scalp electrode, that's just like if you were doing a 12-lead EKG on a patient, that's direct R-to-R intervals. So remember that one. And then the other one's the ultrasounds. Just if it's the machine, it's going to use the autocorrelation. And if it's ultrasound, it's detecting the shape of the heart walls. So just remember, ultrasound, that's what it does. It measures the shape. The TOCO detects the shape of the uterine walls. And IUPC measures the hydrostatic pressure within the uterus. So that is a direct line of the pressure. So a lot of times when I put patients on the monitor and they're looking at their contractions and they may be completely flat and they look like they want to rip my face off. And then I've had some hit the top of the page and talk to me like I'm talking to you. And I always tell people, I don't use that to tell intensity. I use this to tell me how far apart your contractions are and how long they last. Intensity is what you tell me it is. So if you tell me you're a 10 on 10 pain, then you're a 10 on 10 pain. Having said that, if you have an IUPC in, that's exactly what that does. It measures the intensity. It measures the pressure inside the uterus. Again, intensity is going to be what they say it is, but it does measure the pressure. And then you get into the montevideo units and stuff like that for measuring it, but that's another lecture for another day. And again, you're going to learn all about these things when you take intermediate and when you go on to do advanced as well. You'll hear all these again. So the doubling of the fetal heart rate. So there are limitations with our equipment, as with anything. Sometimes you'll get a doubling in the presence of the rate greater than 240. So maybe your rate is 120 and the machine's doubling it for whatever reason. It can't detect the source of electrical impulse in the heart, so therefore it's unable to differentiate between the atrial and the ventricular arrhythmias. It'll drop beats, which can appear as downward spikes. We've all seen that before, I think. And premature beats can appear as upward spikes, immediately followed by downward spikes. So you get those up and down straight lines. If you've ever seen a pacer spike on an adult, it kind of looks like that. In the case of fetal demise, the FSE may detect electrical impulses from the maternal heart and record the maternal heart rate. So we all know that these machines are just monitors. They're just looking for a heart rate, and it doesn't care which one it gets. That's very true of the ultrasound one. The FSE, we're always, okay, yeah, it measures the R-to-R complex. It's directly attached to the baby's head. However, if that baby doesn't have a heart rate, it can definitely pick up one for the mom. So that's why our pulse oxes are so important. And honestly, that's not A1 standard, but remember I told you can always go above A1 standard. You can't ever go below A1 standard. So the whole reason that we use the pulse ox the way we do now is because an incident similar to that did happen where we were getting a heart rate in the 120s and mom was perfectly fine. And it really did look like a fetal heart rate, but we didn't know, and it was just picking up moms because it was just looking for a heart rate. So for whatever reason, she was in the 120s. But when you look back on the monitor strip, you can literally see where the point of insult occurred, and it was literally like 2 hours before that baby was born. So that baby was born not alive. So that's why we use the pulse ox. So for good or bad, it can be a pain in the ass if I'm honest, but it is a really good tool to use. And people have heard me say this many times before too. If you're getting a wonky reading or mom and baby are very, very close together and you're not really sure, grab a radial pulse. And sometimes I will crank the monitor up and I will grab a radial pulse and I'll listen. And if that thing sounds different than what I'm feeling, then I know I have two different ones. Otherwise, sometimes it can be very difficult to tell, even with the pulse ox. So, when in doubt, use all your tools, including your hands. So, yeah, so the doubling happens when the monitor incorrectly interprets one beat as two, resulting as a double fetal heart rate on the monitor. And then halving occurs when the monitor only detects one every other beat, so it displays the heart rate as half the actual rate. So, and that's why I said it may occur like close to the mom's. Now, maybe the baby really is that low. Maybe it's halving it. Who's to say? In that case, I would probably get an FSE. Okay, so I put this in because this is a good picture of probably, most likely, hopefully, a strip that's a heart rate that's doubled. I mean, who's to say for sure? And I'm talking about the top one, not the bottom one. I know this is super hard to see, but from my eyesight, it looks like the kid's got an arrhythmia going on. And an arrhythmia, you can see it and you can really hear it. A lot of times I'll hear it before I even see it. Like you just, when you're so used to listening to it, you can pick it up and you'd be like, something's not right. That kid has an arrhythmia. And a lot of times these arrhythmias will resolve themselves as soon as the baby's born, but not always. Fortunately, in the day and age that we live at with all the, MFM and ultrasounds that we do. My day, you got one freaking ultrasound. You were lucky to get it at like 30 weeks or something like that, 28 weeks. Am I right, Ann? And now they're getting them at like 10 weeks or something. I don't know. You're getting like 6 of them. But anywho, yeah, now we're pretty good at them. Whereas if the kid has a congenital defect or some sort of cardiac anomaly or issue, they're already getting picked up and they're already getting shipped over to Albany Med because we don't deal with that stuff here. A lot of these kids are going to need surgery as soon as they're born. So, but you can have an arrhythmia that wasn't noticed before. And like I said, 9 times out of 10, it's going to resolve itself. Those are the kids. I don't do a quick, 6-second and multiply by 10 like I usually do. I listen for a full minute. If I have an arrhythmia, I'm listening. I also forewarn my pediatrician just in case. Like I said, usually it's not an issue, but the one time it's an issue, just make them aware that they don't necessarily have to be there for the delivery. Like I said, they usually resolve, but if they're around, I let them know for sure. But in this instance, that might be one that is actually doubled. So it doesn't look like a necessarily good tracing anyway. So is it an arrhythmia and the kid really is that tacky? Is it doubling? Who's to say? Another thing you can do is, you got your pulse ox on, you're listening to mom. Listen with your ears. Like I said, a lot of times you'll hear that difference in sound and you'll hear that arrhythmia. If it's an arrhythmia, then it probably is tacking away like that. Otherwise, it might just be doubling. But you can also, if you have a really good stethoscope, you can literally put it on the mom's belly and just listen. And sometimes if you get a really good cardiac Littman stethoscope, you can actually hear the baby's heartbeat. So, and then back in the old days, we used to use a fetoscope. Where's that thing like you put it in your ear and you put it down? But it worked. All right. Sorry about that. I needed a sip of water. Okay, moving on. So maternal or fetal heart rate. So either can be detected by both external monitors or an FSE, like we just said. It's based on functionality of the monitors. The maternal heart rate sounds different. So like I said, mom should sound different than the baby, and arrhythmias can sound a little different as well. So just always use your ears. Fetal heart rate should possess a drum sound. So we've all heard that ba-boom, 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 ba-boom. And it should capture the valves opening and closing. The maternal heart rate should possess a whooshing sound. So a lot of times I'll see this, especially, no offense, with the newer kids, but you got somebody that's in the tub or in the pool and you're going to get a Doppler and you put it on, you hear whoosh, 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 and you're like, yep, and it's picking up a number and it says 120. Like, yep, nope, baby's doing great. I'm like, nope, that's the placenta. So you'll hear that whooshing sound. So you're either getting mom or you're getting the placenta, probably the placenta. but the baby's going to have a distinctive sound. So when it's on the big boy monitor, over here, as I like to call it, you'll get that drum sound. When it's on the Doppler, you'll get more of almost like a clickety cloppity horse sound. You know what I mean? You know what I'm talking about. Like if you hear it, you know what I'm talking about. So if it doesn't sound right to you, just keep that in mind. But the whooshing sound is definitely not it. So keep looking if that's the case. And if you can't get one, you try them with a Doppler. And a lot of times if we get young kids in here, 20, 21, 18, 16 weeks, I'll forewarn them. I'm like, listen, this monitor is geared towards the big kids. It's just a monitor. It's just looking for a heart rate, and it doesn't care what heart rate it's going to get. I said, so I might actually get your heart rate. So I don't want you to be freaked out if I can't find it. So I always like to just preemptively put that out there. So if I don't get a heart rate, now it's going to freak them out. And that may or may not be the case. So I always try with the big one first. And sometimes you'll be surprised. You put it on like a 25-weeker and it's like, you're getting a great strip. And then sometimes you can put it on a 30-weeker and you can't hear shit. So if you get the Doppler, that's why it's really important that you want to make sure that you can hear it. If you're still not getting it and all you can get is that whooshing sound, get an ultrasound. So that's always your answer. If somebody doesn't pass their NST, get an ultrasound, get a biophysical. If you can't get a heart rate, get an ultrasound. So whether that's just one of the providers coming up and you put the ultrasound on yourself and you just look at it and hear it, or say we can't really hear it on there, but you can see it, fine and dandy. If that means you get somebody coming up from downstairs from the ultrasound department, fine as well. All right, so the use of the maternal heart rate monitors via the ECG or the pulse ox can assist with differentiation. We just talked about that. Extra caution should be used in the presence of maternal tachycardia and or a low fetal baseline. So yes, you can have kids that run low fetal baselines, like low 110s. Pardon me, you can also have moms that are in the 120s. That happens a lot, actually. So you really got to be careful and make sure that you are picking up baby and not mom. So again, this is where our pulse oxes really come in handy. Okay, and this one is just an example of how, I mean, you see these little spikes over here where it looks like pacer spikes. I actually put this in because to me it looks more, and this is not the case because clearly this is baby over here and then it starts picking up mom. So my point is, this is just a monitor. It's just looking for a heart rate and it doesn't care which one it's getting. So you can see where it was picking up fetus to begin with. And then when the fetus decided it no longer wanted to have a heart rate, it switched over to mom. So a sad picture, but you know, if you can visually see it, I think it helps a little bit. All right, types of fetal arrhythmias. You have an irregular rhythm, which counts for 90% of your fetal arrhythmias, and they're usually due to PACs or PVCs, which are intermittent, ectopic, or skip beats. And again, you and I sitting right here right now are probably throwing some PVCs. You wouldn't even know it. Sometimes you know it. Tachyarrhythmias, they account for 5%. Those are your supraventricular tachycardias, your atrial flutters, and your bradyarrhythmias, which account for 3%, which are your complete third-degree AV block or your arterial ventricular block. So I'm going to say, if you have a baby with a known tachyarrhythmia, whether it's A flutter, supraventricular tachycardia, or worse yet, complete third-degree atrial ventricular block, those PVs should be going to Albany Med, and hopefully we already know about them. Again, anything can and will happen, and they can pop up here. But hopefully we shouldn't have to do anything with them. But there are things that you can do with kids, especially like SVTs. You can give them DIG and stuff like that. But that's well out of our scope of practice. They do that over at St. Pete's in the NICU? I'm sorry. Do they give the kids DIG if they have SVT? Or they go to Albany Med?
No, not SVT. They'll try ice to their face. They'll try something bagel first.
Okay, yep.
And then they've done like amiodarone or something.
Yep. But
yeah, I never saw them give DIG.
Yeah. I thought that might be above their scope of practice, but you never know. All right. So this next slide, it says irregular rhythm, and it is, but if I'm honest, a lot of that scribbly portion looks more to me like artifact. And I'm going to show you a picture in a minute, but we've all seen this. Especially if you have someone that has an FSE in, a lot of times there can be a couple of things. It can be electrical interference. Like I've noticed if mom, especially now in the days of cell phones, if mom takes her cell phone and lays it on her belly, a lot of time, and they have an FSE, a lot of time you'll get something that looks like this. You're like, you got to move that. And they'll move it and they'll go back and you'll be like, oh, hallelujah. But a lot of times, if you're getting a strip like this, it's either, and there's an FSE and it's either not well applied, it's not in the right spot on the head, or it's in the right spot, but it's rubbing up against the cervix and you get that interference. So that's artifact. But definition, irregular arrhythmia, usually benign and resolves itself shortly after birth. And it's any irregularity of the fetal cardiac rhythm or any regular rhythm that remains outside of the general range of 110 to 160. And it's not associated with uterine contractions, doesn't have anything to do with it. All right, this is what I was talking about. So if you look at this one, they're a little bit more, what's the word I'm looking for? Like condensed, I guess. I don't know. That to me looks more like an arrhythmia than the first one. So as far as artifact versus arrhythmia, although I don't like the tachysystole down the bottom, that is crazy. So if you have areas where it's uniform, meaning it looks like a little colored in area, and you'll see it on the monitor, it just looks like somebody took a pen and just was like coloring scribbles all the way across. That's an arrhythmia. If there are excursions that go up and down every kind of which way, there's no shape or formity to them, that's usually artifact. And again, if you just picture the one that I know we've all seen where, you know, the FSE is placed and it's either, and sometimes it might even be the sticker's not well applied to the leg, get a new sticker. That's always where I start first. Get a new sticker. If the new sticker doesn't work, get a new plug, like the whole thing that plugs in. Before you take it out of their head, try those two things first. 9 times out of 10 that works, but you know, if not, they might need to replace it. So anyways, for the test, because I guarantee you there will be a question on the test, they're going to show you a strip that's a nice little uniform of block of scribbles. That's an arrhythmia. But if they go up and down and they're all crazy and all over the place and you can't really tell, they don't really look uniform, and you see it's with internal monitor, that's artifact. So sometimes if it's, like I said, if it's not in a great spot or it's rubbing up against the head, that's where you're going to see it. So, and I remember there being a couple questions about that there. So next one. And tachyarrhythmia, again, this is, if I'm not lying, the same strip that I used the last one, but you know, who's to say if it's tachyarrhythmia or if it's doubled? So the picture works for both. So the fetal SVT, if left untreated, can result in non-immune hydrops. So hydrops is a serious condition that occurs when there's abnormal amounts of fluid that builds up in 2 or more body areas, and it causes swelling, and that can interfere with organ function and often leads to infant death. So usually if you hear someone's got hydrops, it's pretty ominous. We don't ever like to hear those. So if they do survive, they can go into CHF, and then I remember a question about that too. So they get congestive heart failures and their little heart gives out. The best treatment, again, like I said, is beyond our scope of practice. If we got someone here like that, assuming they survived, or if they knew about it and they were a maternal transport, I would ship them straight to Albany Med. Don't even pass go, just give them. And they usually are going to do, like I said, like they'll do a drip of digoxin or something like that that would help to cardiovert the baby's heart. But again, what you need to know for the test is that the treatment for SVT would usually be like a digoxin or something like that. The therapeutic regimen is controversial. Like I said, the risks benefits analysis needs to be weighed, and it's dependent upon the absence or presence of hydrops and the gestational age. So again, and Ann talked about this too, the drug regimen can include digoxin, fluconazide, saltolol, and amiodarone. None of which we're doing here. None of which. And then you got your 3rd degree or complete heart block, which looks like absolute garbage, and nobody wants to see this strip. And 50% of it is associated with congenital heart defects, so transposition of great vessels, for example. And 50% is associated with maternal antibodies, like a patient that has lupus. So the transplacental passage of antibodies around 18 weeks can damage the fetal heart, so that's where you're going to get your congenital. And unfortunately, it's just not compatible with life. So. Antenatal testing. So you can identify and intervene when a fetus is identified to be at risk before an injury occurs. So a fetus who's influenced by disruptions in oxygenation will attempt to compensate. So babies are very good at compensating until they're not. And then when they decompensate, boy, do they decompensate. And that's true of little kids too, like babies and little kids. They're great, and then all of a sudden they get sick. They're not good. So notable signs of developing hypoxemia or metabolic acidosis can include hypoxemia, shunting, decreased renal perfusion, decreased amniotic fluid volume, acute hypoxemia, and a decreased movement in late D cells. So again, you can see that little pathway here. That's just a quick down and dirty thing that hopefully will just help you remember, because there'll probably be a question about that as well. Non-stress test. So a reactive non-stress test is greater than 2 ACT-cells in 20 minutes with or without perception of movement by the mother. So back in the day, we used to do a non-stress test, and we used to give them, matter of fact, I think a couple of these monitors might still have them. I used to call it a Jeopardy button. So if you ever watched Jeopardy, the button would literally plug right into the machine, and anytime she felt the baby move, she would push the button. And then, we would look to see how many movements she has. We don't have to count the movements anymore, and that's not really important. I mean, we were also looking for ACT-cells, don't get me wrong, but we were also looking to see how many movements she felt. So, but the perception of movement does not have to be there. What does have to be there is at least 2 ACT-cells, meaning 15 by 15, if they're over 32 weeks, over 20 minutes. If they're under 32 weeks, 10 by 10. And we're not really doing them too much younger than 32 weeks, like maybe 28 weeks, but definitely not anything under 26 weeks. Anyway, a non-reactive non-stress test lacks sufficient fetal heart rate ACT-cells over a 40-minute period. So we want to see 2 and 20. We give them 40 minutes total to pass the test. And again, if they don't pass that test in 40 minutes, it requires further testing. And what do you do if you don't pass a non-stress test? You're going to get a biophysical. So consider your gestational age, consider your fetal sleep cycle. So a lot of times when they come in, I give them juice right off the bat. And first thing I ask them is, are you diabetic? If they say no, I give them 2 things of juice. And I tell them to take it like they're doing shots. And then I'll put them on the monitor and watch them for 20 minutes. And, if they haven't had anything to eat or drink in a while, I'll give them something to eat as well. If I have anything, whether it's yogurt or pudding or graham crackers are great, whatever, something with a little sugar. Kimmy Bouchard, are you guys here for Kimmy? No? Okay, sorry. Well, Kimmy would give them juice, and then she put like 2 sugar packets in it, which is also great. That will elicit your response, hopefully. So my point is, I always say I'm like a good grandma. I sugar them up and send them home. So get them bouncing around and then send them home. But yeah, so also you need to consider if they've had any kind of sedatives. Did they take Benadryl or anything like that? Fetal cardiac or central nervous system abnormalities, and hypoxemia. Contraction stress tests. So we don't really do these anymore, but you still need to know about them. And it was on my test. Granted, that was 6 years ago, 7 years ago. But anyways, it was a while ago. But they were on my test, and I'm sure they still do them somewhere out in the world. And it's not completely outside the realm of possibility. So you should at least have basic awareness of them. So a negative contraction stress test is exactly what you want. So it sounds funny, but that's what you want. You want negative. So negative, just think N for negative, N for no late deceleration. So it's negative, meaning you stressed them out and they didn't throw any variables or lates or anything like that. So negative means no late or significant variable decels. A positive contraction stress test means you have recurrent lates, even if the contractions are less than 3 and 10-minute periods. Equivocal is suspicious, meaning you can have intermittent lates or significant variable decels. The decels in the presence of contractions are greater than every 2 minutes and last longer than 90 seconds. And an unsatisfactory one is less than 3 contractions in a 10-minute period, or it's uninterpretable tracing. You just can't read it. So the fetal surveillance considerations, the goal with that is to identify women at high risk for stillbirth and decrease the risk of fetal demise after 24 weeks of gestation and avoid any unnecessary interventions. So the initial testing occurs between 32 to 34 weeks, and it's appropriate for most, but sometimes they'll start as early as 26 to 28 weeks. It depends on the patient's history. If they've had early losses, like stillbirths, things like that, they'll start early. And when the clinical condition that prompted the testing persists, a reassuring test like a reactive NST and a negative CST, like I said, that's a normal result, that's a desired result, okay? That means that the baby can tolerate the stress of labor and the contractions, and there's no signs of fetal distress. So this can be done with Pitocin or even a nipple stim test. So contraction stress test, yeah, you can either use Pitocin to elicit your contractions, or you can do nipple stim. So nipple stim is exactly what it sounds like. Women will just go in and pinch and roll their nipples to release the oxytocin that's naturally free-flowing in their body, and then that will give them, hopefully, the hormone reaction to contract. And so you use it that way. Although I will say 9 times out of 10, anytime I've ever done it, it's been with Pitocin. So, like I said, we don't really do them here anymore, but that's not to say they're done elsewhere. So, like I said, normal BPP, and these should be, it's usually done with a normal BPP, and these should be repeated 1 to 2 times a week, depending on the task and the high risk situation why we're doing it, up until the time of birth. I didn't give them TERB, but I guess that would depend on the situation. If they started going into like a lot of contractions, not necessarily tachysystole, but if they're starting to get persistent, in that case, you're going to want to do some prolonged monitoring. Maybe give them an IV. I mean, they're going to have IV anyway, so flood them with regular fluids. If they were on Pitocin, I would stop the Pitocin, flood them with fluids, and take it from there. You certainly can give them terbutaline, so that's a good question. Again, that's going to be provider preference. Some providers we used to give it all the time, and now I can count on probably 2 hands the amount of time I've given it in probably the last like 10 years. The only time we really give it now, if I'm honest, is when we're doing versions. And again, even then, provider preference. Some providers will, some providers won't. And even patient. Like, they may do it on this patient, they may not do it on the next patient. So you never really know. But yeah, good question. And of course, if you have like a 26-weeker that's contracting like crazy, you're not going to send them home anyway. So you're going to keep monitoring them until you either fix it or, they have to go to Albany Med or something. All right, so umbilical artery Doppler velocity. So this assesses the vascular resistance to blood flow in the placenta. It's useful in monitoring growth restriction related to placental insufficiency, so your IUGR kids. Increase in placental resistance, there's an increase in the SD ratio and an increase in the end diastolic flow. And absent or reversed end diastolic flow is abnormal and associated with increased morbidity and mortality. So again, that's your insufficient placental perfusion there. So your biophysicals. So an NST can be considered part of your biophysical. You can actually get points for that. Usually a biophysical is 8. The most you can get is 8 out of 8 points. It has 8 points total. If you need to, you can throw in the NST component and get an extra 2 points that way. So unlike APGAR scores, where you can get 0, 1, or 2 points, in a biophysical, you're either getting no points or you're getting 2 points. You either have it or you don't. And unfortunately, it's much like us, it's at the time that you're monitoring it. So at the time that you're witnessing it, that's when they're scoring it. So what do we count? We count, and by we, I mean ultrasound. This is not something that we're doing up here. This is something that they're going down to the actual ultrasound department for, or ultrasound can come up to us, depending on your situation. So what they're looking for is fetal breathing movements. So what they want is greater than 1 episode of rhythmic breathing for greater than 30 seconds over a 30-minute period. They're looking for fetal movement, so greater than 3 discrete body or limb movements in 30 minutes. And fetal tone, so active extension or flexion of their extremities, so their hands, whatever, or even their feet in 30 minutes. And the amniotic fluid volume. So there's 4 pockets of fluid. They only need to do 1, but that pocket has to have greater than 2 centimeters in 2 perpendicular planes. And the single deepest pocket has to have greater than 2 centimeters of fluid. And so a lot of times when we're doing this, I will, if I'm sending somebody downstairs, I usually tell them, please send me up a preliminary report, because these the ultrasonographers will do them, but they're not the ones reading them. And so it has to be our radiologist is usually 99 times out of 100 not here. They use an outside, especially at night. They use an outside, what the heck do they call them? Sky docs or fly docs? Helicopter docs? I don't know. Whatever they're called. It's some company that they use, and that's what they do. These radiologists sit there and read this stuff. So anyways, my point is, if you're sending someone down on a Friday night at 10 o'clock, good luck. You probably won't get a result till Monday morning. Even if it's stat, like it takes them forever to read it. I might be exaggerating a tad bit, but they're certainly not quick to jump on it. So I will usually ask for a preliminary report, or if it's really super stat, I will call downstairs and I'll be like, you need to call the radiologist and you need to tell them to read this right now, because I need to know if we're sectioning this girl or if she's going to Albany Med or what we're doing. And they're usually pretty good about getting a hold of somebody and having them read the test. But 9 times out of 10, they know what they're looking for. They know if they're seeing fetal movement. They know if they're seeing fetal breathing. They know how much fluid is in the pockets because they're the ones that measured it. And they can kind of tell you. And so sometimes they'll send me up with a piece of paper. It'll be like 8 out of 8, 6 out of 8, 4 out of 8, whatever it may be. And then they'll tell you what the findings are. Like, this is what we took off for. This is what we gave points for. So a word of caution with that. I did have one time where they sent me up a girl with a preliminary report, thank God. And she's like, yep, nope, she's 8 out of 8. So the midwife, who's no longer here anymore, was ready to send her home. And I happened to look at it. And I go, wait a minute. I go, they gave her 2 points, but she's got less than 2 centimeters of fluid in pockets. I go, she's only got 1 centimeter. She's like, what? I said, so now it's a 6 out of 8. And so if she had a reactive NST, which I don't remember, great, you can add that in. And now you get 8 out of 10, which is okay. But if you got a 6 out of 8, you're probably not sending that patient home. You're either going to do continued prolonged monitoring or you're going to induce her. So 6 out of 8, that's usually like crap, because you know they're not going home. And so that girl did not go home. Matter of fact, I think we induced her. And then I had one come back not that long ago. That was also 6 out of 8. So anywho, that's your biophysical. And I will say, make sure you know this and know it pretty good, because there will be a question on the test for sure, if not a couple. I need to know how it scored, what they scored, and your fluid volumes and stuff like that. So again, you get a score of 0 or 2 for each category. You cannot score 1 like APGARs, like I said. And the composite score, 8 to 10, is normal. So a biophysical in and of itself is 8. There's 4 categories, 2 for each. That's 2, 4, 6, 8. You can add in the NST component. So if you have a reactive NST, that is also 2 points. If you don't have a reactive NST, that is 0 points. So you can only really use it if it's reactive. Because sometimes they'll send them over and do an NST and a biophysical. It's not just, oh, you failed your NST, go do a biophysical. If I'm remembering correctly, I think the whole reason we did the NST on the one girl that got the 6 out of 8 is because she failed her biophysical or her NST. So we sent her down for a biophysical. Now she got a 6 out of 8. Now we really got to do something with her because she failed her NST. She got a 6 out of 8. I can't even get her an 8 out of 10, and take off for that one thing. So that's what happened with that one. All right, so if the score is 6, it's equivocal, and the decision for follow-up testing versus proceeding with delivery should be made within the context of the gestational age. So what that means is a lot of times, usually 9 times out of 10, if they're taken off for something, it's for fetal breathing, which is kind of crazy. So we're, as crazy as that sounds, we're kind of less concerned with that. So they might be okay with sending them home, especially like I said, you get a 6 out of 8, they took off 2 for breathing, then you had a reactive NST, you can make that 8 out of 10. If you don't have a reactive NST and they gave you 6 out of 10 or 6 out of 8, then it's up to your provider. 4 out of 8, you're definitely not going anywhere. That person's got to be delivered, or at least go to a higher level of care, depending on what the issue is. That's definitely something abnormal. But again, it's just going to come down to why they took it off. If you're getting a 6 out of 8 and you have, a reactive NST, so now you're 8 out of 10, but they took off for fluid, then that's also something that you need to consider. So it really is going to come down to, or if it was fetal heart rate, although that's actually untrue because it's either there or it's not. So you're not going to get a partial credit for fetal heart rate. So if you get a 0, it's because they're not detecting a heart rate, or it's at least not normal. So forget I said that part. But yeah, if it's for fluid, they might want to induce you sooner rather than later, because you can have all sorts of problems with low amniotic fluid, as we all know. So regardless of the composite score in the presence of oligo, which, we were just talking about fluid, if the AFV, which is the amniotic fluid volume, is less than 2 centimeters in the deepest vertical pocket, then further evaluation is needed. So, and actually, it's really AFI, amniotic fluid index. Amniotic fluid index is the one that you use to check your pockets, whereas amniotic fluid volume is to check the overall fluid in the whole cavity. So, all right, practice time. So, I apologize. I don't think we have the slides for this one, but what I will say is there are some during the next slides anyway. So bear with me. Some of them are kind of crappy, but what we're going to do is we're going to look at the baseline. We're going to determine baseline, variability, whether there's accels present or not, whether there's decels present or not, the contraction pattern. Is she in a good contraction pattern? Does she have any contractions? Is she in tachysystole? And remember, if you're not picking anything up, palpate, palpate, palpate. That will also be on your test. And what category strip it is. And remember, for your tests, you're only going to get a small snippet similar to what I'm going to show you. So some of them might be indeterminate. You might not be able to tell because it's such a small piece. But, if you had a full tracing, you'd be able to do it better. So let's see. All right, so this first one I think is pretty good. This one's actually halfway decent. Some of them are better than others, so I apologize. I can actually see the numbers on this one, so that's good. So we're looking at this strip now. So the first thing we're going to look at is our baseline. So we've got a baseline of like 120, 125, about 125. Would we all agree with that? All right, we got some moderate variability. And we have some positive accels. I don't really notice any decels there. No uterine activity to write home about. So this would be a category 1 strip. And this is pretty much exactly what you're going to do on your, sorry. Why is it? Oh, shit. Sorry. Shoot. I meant shoot. Trying to be professional on the radio here. This is just what you're going to do on your exam. You're going to get the strip, and you're just going to break it down step by step. So here you have in the purple, they're showing you the accelerations. So you got your 15 by 15, meaning it goes up 15 beats above the baseline. All right. And it's lasting for at least 15 seconds long. And remember, each one of those little boxes, which are very difficult to see, are 10 seconds. And then the big line to the big line. Actually, the little boxes aren't so difficult see, but the dark line to the dark line is 1 full minute. So you got your baseline for the majority of the testing is anywhere between 125 and 130. Sometimes it goes above, sometimes it goes below. So when that happens, if you can see, especially in the first minute and the second minute, you got some that's right on the line, some that's below the lines, and then the next minute, some that's above the line. So what you can do in that instance is you can go middle of the road and split it in half. So if you got like 125 on one, 135 on the other, you go middle of the road and you round it off to the closest 5, which would be 130. And so we have baseline variability, which is moderate. So you have at least 6 to 25 beats per minute. And so that would be your category 1 strip. So the next one here, it's a little flatter, but not completely flat. So it looks like some minimal variability. You are tacking away here. This is a tacky baby. So it looks like to be, from what I can see, about the small lines. I think I'm seeing a small line there. So it looks like it's about 175. And then you're contracting every couple of minutes down below. I don't see any accels. I also do not see any decels. Not that this part is on the test. However, one of the first things I would do if I saw a strip like this would take a maternal temp. Because if you got a tacky kid, then that could be indicative of sepsis. Excuse me. So we have an abnormal baseline because it's tachycardic. It's above your 160. Minimal variability. You could argue moderate there. It's kind of hard to tell because it's so small. So minimal to moderate. I mean, this is one of the cases where you could actually use your, I guess maybe actually I think it is more moderate, but you could use your tools in your Obix. Thank you. That's the word I was looking. I was going to say OB Traceview. That was the other program we used. Obix. Yeah, that was the old one. Anyways, your tools in Obix, and you have something in there for accels, you have something in there for decels, you have something in there for contractions, and you also have something in there that you can put over. It's like a little box. You hover over the top of your baseline, and if it fits inside the small box, then you have minimal variability. If it juts outside of the box, then you have moderate variability. And that's something that you're going to want to move around so you can see what the majority of your strip is. Because as we all know, sometimes you'll have minimal with periods of moderate, sometimes you'll have moderate with periods of minimal. Depending on what's going on, may or may not be anything too significant. You might have a baby that's sleeping. But in this case, like I said, the baby's tachycardic. So moderate variability or not, and I do believe that is probably moderate variability, it's still abnormal because it's tachycardic. So moving on to the next strip. And there it's showing you the tachycardic rate. Although when you do it like that, it does look more minimal like that though. And your baseline, like it said, is 180. And like I said, once it drew the line, you could see it's more minimal there. But that's, again, one that I would want to use the box for because it's hard to tell, especially because I don't know if you guys can see them, but the teeny tiny boxes that divide the bigger boxes for me are almost impossible to see. So I apologize. My screen is a lot smaller than what it usually is too, so it's really super small for me right now. I don't know why I put that there because there ain't nothing there. I don't know. Enjoy the free slide. One less slide to go. I think I must have. Are you guys seeing a full strip or am I crazy? Are you seeing the same thing I'm seeing? This is 156. Are you seeing anything? Okay, I apologize for that. I think I cropped the slide and I must have cropped out the freaking, what do you call it? Where the heart rate is and stuff. So I apologize for that. So sorry, we're going to skip a couple of slides then because I don't know how I did that. Yep. Have fun with that one. Sorry. Anywho, regardless, the things are the same. You're going to look at your baseline and see what your heart rate is. You're going to look at your variability. You're going to look, do I have accels? Do I not have accels? Do I have decels? Do I not have decels? You're going to determine your contraction pattern. Am I in tachysystole? And then you're going to determine your category. Are you in category 1, category 2, and category 3? And remember, you're going to do that for every single solitary strip that you get handed. If you do that, and you, like I said, if you know your category 1s, you know your category 3s, category 2 is everything else. If you can determine that, you will be in good shape. And the rest is mostly what we did in the first half, which is going to be physiology, which unfortunately kind of sucks, but you just got to get through a lot of it. That's better. I mean, it's not better, but you know what I mean. Now this one again is wicked hard to see. I think that's 150. I can't really read it. That's not the purpose of it anyway, but still, I believe it's 150. Okay, so there's our baseline. It's looking pretty flat. So minimal variability. So if you have minimal variability, you already know off the bat. I mean, you know off the bat as soon as this thing popped up before you even knew what the heart rate was or anything else, it's automatically a category 2 because you have variables in there. So I shouldn't say automatically a category 2. If you had absent variability with recurrent variables, it would be a category 3, right? So I shouldn't say absolutely. But, you know, you can see some squiggles there. Again, you don't count variability inside the D cells, whether it's a variable or a late, because you do have a late there as well, if you can see that on the very first minute. Okay, so we don't count the variability. So you're looking at variability outside of those. So in between the late, in between the variable, and then in between the two variables. So you do have a little bit of amplitude to that, but it still looks pretty minimal. But again, if I couldn't see the boxes before, they're non-existent in this one now. So I apologize. They're not as, I can only do with them what they send me. So, all right. So there you can see your heart rate. It is 150. So at least I was right about that because I cannot see the numbers. So that was pretty good math. And it looks pretty minimal, which we'll see on the next slide. Okay, so you have minimal variability. And again, that's less than 5 beats, and absent will be 0. Minimal is 1 to less than 5, and moderate is 5 or 6 to 25 rather. And then anything above 25 is going to be marked variability. And I don't even think we really talked about that, but we will, I'm sure. Marked variability is neither indicative of being good or bad. It's just okay. It's kind of indeterminate, really. So, all right, and there's your late deceleration as advertised. And there are your two variables. So all of those things, any one of those things really would have been enough to categorize it as a category 2 to begin with, but all of them in conjunction with each other definitely solidified that. Okay, so here's a good picture of some marked variability. So what do you think your baseline is here? Any guesses? Correct, that is indeterminate. If you have marked variability like that, there's no way to determine a baseline. So there's no way of knowing. Again, marked variability, not necessarily bad, not necessarily good. It's just okay. But you cannot determine a baseline. So therefore, you're going to call that indeterminate. So again, like it says, baseline's indeterminate due to episodes of marked variability. Fetal heart rate's anywhere between 130 to 170. And even if it was, you know, 120 to or 110 to 160, which is still in normal range, it still would be considered indeterminate. So your answer for that one is indeterminate. You can't categorize it. You don't know anything about it because you can't tell if there's X cells, you can't tell if there's D cells, you can't tell what your baseline is. The only thing you could tell, which I don't even remember what the strip looked like anymore, is what the contractions were, but that's irrelevant at that point. Okay, so here's another one. So, and this one's honestly really not kind of fair because it's very short and you wouldn't get one necessarily this short on your test. So this one's kind of tricky. But there's really not. Remember I told you if you had at least 2 minutes, you could pop them together. So this one more or less looks like a prolonged D cell because you can't, there's not enough information there basically. So yes, you have some moderate variability up in the top, but there we go. And there's your decel. And so before I hit the next one, do we know? Oh, it already did it. I was going to ask you if you knew if it was abrupt or not, but that's a trick question because it has to be, it can't be more than 2 minutes because 2 minutes would make it prolonged, but it has to be less than 10 minutes because 10 minutes would be considered a baseline change. This is some fugly stuff right here. This is something you don't ever want to see. And without saying that, do you know what this is? Let's start with our baseline. So what's our baseline on this one? 180, yep. And do we have minimal, moderate, absent, marked? What do we got? Absent, yeah. And then, so absent in and of itself, not necessarily a category 3. So let's take it one step further. Do we have any accels? Not usually with absent, although you can have little periods of absent and then all of a sudden some kid will do something funky, but not in this case. Do we have any decels? Yes, we do. Do we know what kind of decels they are? Those are late. They start after the contraction. So you have both your onset, your nadir, and the end of the contraction are all after the contraction happens. So these are literally textbook late decels, which are great. And that's kind of sort of what hopefully you'll see on your exam. They're not trying to trick you. They just want to make sure that you know what you're doing. Unlike the kids in the real world who don't give a shit and they'll throw you variables and everything else just to try and make you go, what the heck? But yeah, so we have, I think that says 180 there if I'm not mistaken. So you have a tachycardic kid to begin with absent variability and recurrent lates. So when we have absent variability and recurrent lates, what do we got? Category 3, exactly. I mean, it doesn't get much flatter than that. So 180, absent variability. And you have your late decels. All right, this one is a little bit better. So again, I can't really see the boxes, and this one looks a little bit more squished than the other one, maybe not. But it looks like you have probably minimal variability. Again, we're not counting the one inside the contraction. Maybe moderate in periods. I might even call it minimal with moderate with periods, or minimal with periods of moderate, but not a lot. Looks like maybe 130, I think, if my eyes are not deceiving me. So there's no accels. We do have a decel. So we're going to measure our decel. So if you're going to start from the time that the onset of the decel, if you draw a straight line down, you're going to see that it starts with the contraction. If you look at the nadir, the peak of the decel, and you draw a straight line down, it's right in conjunction with the peak of the contraction. And then if you look when it returns to baseline, the decel that is, and you draw a straight line down, that's also in conjunction with when the contraction ends. So you have the onset, the nadir, and the end return to baseline all occurring at the exact same time with the contraction. So it's mirroring the contraction. Then do you know what kind of accel that, or excuse me, what kind of decel that is? Correct, that's an early. And those ones are okay. Those are your head compressions, once again. And again, you can see mostly minimal. Maybe, like I said, maybe with periods of moderate, but not very much. And again, way too short to tell, but what you're looking at there, no. And that's an actual picture perfect early, which that would be lovely for me. So going back to that slide for 1 second, even though earlies are okay, because that was minimal variability, that's still a category 2. So this one, it couldn't be any sweeter. You could probably just tell what this is just by looking at it. So you have moderate variability. You have a heart rate about 120, 125 in some places. You have some beautiful accels, no decels. Your contraction pattern is nice. So do you know what category that's going to be? That's a category 1. And again, when you guys go to moderate, moderate, intermediate. I'm looking at my variability. When you go to intermediate fetal monitoring, you're going to be doing so many of these, you will have them like that. Like they're just going to be second nature to you. And this is a lot. I think it's still a 2-day course, right?
No, it's one.
It's 1 day
Yeah, it's
now?
one.
Oh, wow. Okay.
Yeah.
But anyway, I'm going to guess 3/4 of your day are going to be spent doing this. So, and you're just going to keep doing the same thing over and over, and it's great practice. So, we're almost done, kiddos. We just got a few more slides to go. Bear with me here. I know this is a lot.
You're doing good at the end of the
Yeah.
class here.
See how I do come midnight. Okay, so anybody want to take a stab at this one? Is there anything right off the bat that looks either great or off to you?
Looks sinusoidal.
It does look sinusoidal, yeah. So in this case, I'm the kind of person that always likes to read into things. When they hand you a strip, you just have to take it at face value and you call it what it is. That's sinusoidal, so that's sinusoidal. If I was here, first thing I do is I would ask somebody who's got this patient, did you just medicate her? If you just medicate her, I'm less worried. If you didn't just medicate her, I'm worried. So, but you can't do that on the test. So you have to just assume what they give you is what they give you. So yes, this is sinusoidal. And what do we say about sinusoidal? What category is that? Yeah, it's automatically a category 3. So you need to take this person in the OR or deliver right now. All right. Another lovely one here. So I think that's 180 it looks like. Again, looks like kind of minimal variability. And those there are what we like to call, well, first of all, do we have any accels? No accels. Do we have any decels? Yeah, we do. So unlike the variables where they have to go down by at least 15 and last for at least 15 seconds, you can have what are called subtle lates. Lates are lates, they're gradual, but there they are. And we know they're lates because if you draw a straight line down from the time that it starts, it's after the contraction. And they're not really, you can have, episodic ones, which, they occur with the contractions, or you can have periodic ones where they're just out of nowhere. These are episodic, they're occurring after every contraction, so those are lates. But you can just have like a normal regular strip and out of nowhere your kid just decides to decel for no freaking rhyme or reason. That would be an episodic decel. Matter of fact, Kristen had one the other day and she was trying to figure it out. I'm like, it's episodic. It just there's no rhyme or reason to it. So that's what maybe just think of that. But anywho, as you can see, there's your 180. Hello, come on. There we go. Okay, and there's your late decels. Now, oh man, I should have showed you this picture hours ago when we were talking about our artifacts and stuff like that. But that's a good picture of that. And if I'm honest, I'm going to guess this girl probably has an FSE on and she's pushing with it. So if you look at the bottom where the contractions are, and that's not what this is about, but it's a good teaching moment, so why not? If you look at the bottom, you see how they're kind of like that fence post kind of jaggedy little thing. That's how you can kind of tell that they're pushing. Also, the way that you can tell that they're pushing is they're literally starting from nothing and it's abruptly shooting straight up. So there's only 2 times that you really see that. One, when they're pushing, or 2, if somebody's trying to fake their contractions. When people try to fake their contractions, they'll just tighten up their abdomen and they'll go, and they'll just clamp down with their belly and make their belly really tight. And the great thing about that is it elicits what looks like a contraction on the screen. But if you look at it, it literally looks like that. It'll shoot straight up, but then they hold it so it goes straight across the top and then it'll come straight back down like these are going straight down. The only difference is where you're getting these little fence post things, that's how I can tell she's pushing. If she was faking her contractions, it would just be a flat top right across the top because they don't know to gradually do it. A real contraction is like a bell curve or like a hill. It gradually goes up, it peaks, and it gradually comes down if you're lucky. So this looks like she's pushing with an FSE to me, not knowing anything about this strip. So, oh, sorry, yeah, we didn't do the things, did we? I got off on a tangent. Sorry about that. So here we have our baseline 160. So technically 160 is still okay. A lot of people get nervous when they see their heart rate right on that line, and then they start to have accels into 165 or whatever. It's like, it's okay. Okay. And there are variable decels in there. You can see that. Okay. You can tell because they're abrupt. I will admit this one's a little harder to read because of all the artifact that's in there. But it is what it is. But that was a great picture of artifact. And so remember what that looked like. That's your artifact. And then remember what the arrhythmia looked like, where it's more like that very close, scribbly kind of blackened in block of little, all heart rates all together. And those are your, your PVCs and PACs and things of that nature. Okay, so this one looks like, I think it's like in the 150s. Yep, I can see it over here. This one's like in the 150s. You got some moderate variability. Again, you got some variables going on. The first one, let's see, 1, 2, yeah, no. So, oops, sorry. So your heart rate's like 150, 155. We have moderate variability. Okay. And here you are. Oops, sorry, I hit the wrong button. There we go. All right. So you have a late decel there. The second one here looks like a variable because it's so abrupt right there, but it wouldn't matter anyway. So you got a heart rate of 155, moderate variability, but you got a couple of lates in there. So even though everything else was okay, that's automatically going to make you a category 2 strip right there. And there's the variable I was talking about. All right, so starting to wrap things up here. So like I said, for the test, and I know it's a ways away, but it's never too early to start preparing. So the more you, even if you just take a few minutes and study a little bit, like even just once a week at this point, by the time you're ready to take it, A, it's going to make a lot more sense to you when you take intermediate. And B, by the time you're ready to take the test, you won't be stressed out. You're going to know this stuff and it'll be second nature to you. There's 125 questions, so 100 are counted. And there's 25 embedded, like I said, so they don't count, but you don't know where they're going to be or what they are. And each question has a stem and 3 alternatives. So we did a couple of them, the review questions, and that's exactly what they're going to look like on there. They're going to be, the answers will be in alphabetical order, and it's all multiple choice. There's no fill in the blanks. There's no tell me what the rate is. Like, yes, you need to know what the rate is, but they're just looking for you to tell them, what is this? What do you do for it? How do you treat this? So you may have a strip and they might be like, they might even give you a story. You got a gravida 3, para 1, 40 weeks. She's doing that. She's doing this. Here's her strip. What interventions are you doing? Like what, like it might be that, or it might be like, is she a category 1? Is she category 2? Is she doing this? Is she doing that? Or why is she having lates? What is the physiology for having late decelerations? It might be something like that, but it won't be a fill in the blank. So at least the answer will be staring at you. You just got a process of elimination. Take your time, read it. You got 2 hours to do the test. It's more than enough time to do it. Trust me when I tell you, it's not that bad. And then, like I said, the tracings are the same as what we looked at. Actually, they're same as ours, a little bit better than what we had here. So if you can go through my stuff, you'll be fine. All right. So, like I said before, spend the majority of the time studying things you either need refreshed in your mind, like maybe it's the lab values. For me, it was my, not pHs, but like my PCO2, my bicarb, acid base I got down, pHs I got down. I can rattle those all day. But even right now, ask me a sodium bicarb. I don't know. Like I gotta look at it. And your difference between your baroreceptors, your chemoreceptors, parasympathetic, sympathetic. Like if you get those things out of the way, the strips are going to come easy to you. But having said that, if you're like, Jesus, I just can't get when it's a variable or when it's a late, then those are things that you're going to want to study. So don't waste your time on things that you already know. Just spend the time on the things, that you need to polish up on. And again, like I said, read the questions carefully. What are they asking for? Don't miss those little, like, except fors or buts or nots or something like that, or which one isn't true, because those will trip you up. And like I said, if you don't know the answer, you can usually eliminate one of the choices, and then you just got a 50-50 shot of getting it right. And again, I said it 100 billion times already. This is a national test, not regional. And just because we don't do it here doesn't mean it's not going to be done. You're not going to be tested on it. And same thing with the, pretermers versus, high risk patients that we don't do. So that is it. Thank you guys so much for your time. I appreciate your coming out. Thanks for bearing with me. Yeah, sorry, I kept you a little bit later than I wanted to. I apologize.